We start in 30 minutes. We start in 25 minutes. I'm behind the scenes still in the necessary machinations. Hello, Tandora Tomita. Hello, how you doing? Hello, Tomita.
Do you hear me?
Yes, hi. Can
Oh,
you hear
good.
me?
Okay.
How
Yeah,
you
I just
doing?
try to. This is John Bennett.
Yes, it is. Hi, how you doing?
Hi. Nice seeing you on the screen. So,
Yeah, is that your presentation up there?
yeah, just I tried test
Yeah.
run.
Yeah, why don't you, yeah, it looks good. You can make it bigger, as you know.
Yeah,
At
it's
the bottom right. Yeah, the bottom right, one of those options will make it full screen.
Yeah, hold on a second. You
Yeah,
just
you'll get it. The bottom right, bottom right.
No, not this one. And
There you go. Perfect. Now it's full screen. You can see it, right?
yeah, I do see it.
Yeah, yeah,
And
that's full screen. It's full screen. So,
but I cannot. Oh, here you go. Oh, you come to the top. Okay. And here you go.
oh, sorry.
You don't see me, do you?
No, I don't see you. I see your presentation.
How about now? Oh, here you go. See, right?
Yeah. Well, if you want to get off the screen, click on the top. It says stop
There you go.
screen sharing. Yeah.
Okay.
Stop screen sharing.
And then new share. If we stop this one, pause share. Okay. How about that? It's paused. Hello.
Yeah.
It's paused. The screen is gone, right?
Yeah, no, I see the screen now.
I don't know how.
No, I can vote you off. At the very top of the screen, it says stop screen sharing. Do you see that?
I said, yeah. That it says a pause share. It says.
I can stop you if you want.
Yeah, screen sharing or stop share. So say stop share. Okay.
Yeah. Hi, Llewellyn.
How you doing, John?
Good. Nice to see you.
Good to see you too. How you, Ted?
Hey, how are you doing?
We're all
Okay,
set.
okay.
I'm ready to blast them out to a lot of people on with
Looks
the
like
live screen. It's a live screen that I send out.
Yeah.
I hope I don't screw up.
No, you'll be fine.
Hey, Llewellyn, we
Yeah.
will screw up. You can count on it. You can count on it. So don't worry about it. Once you understand that, you know, once I started like saying, hey, you know, we'll just see how it goes. You know, we'll make little problems. Don't worry. As long as we avoid the major tech glitches, which we probably will.
Okay.
Saeed, welcome. Welcome. There's the this is like a TV show. Introduce you.
Hello, welcome. How are you, John?
Hey, there's Saeed. Saeed is the head of the French neurosurgery grand rounds every Friday or Saturday.
Okay. Okay.
Welcome.
Hi, Saeed. Nice to meet you.
Hi, nice to meet you too.
And we have the Salazars here too. The Salazars, are you guys here? They may have stepped away. The two neurosurgeons from Mexico. I'm not sure if they're pediatric or not, but I just wrote to Griselda. She's a big pediatric neurosurgeon in Mexico.
Okay.
But we'll get a good crowd. We had 200 what do you call it, registrants, probably more, but I haven't checked it lately. So your presenters, you've done these before, right, Llewellyn?
Yes, yes, we've done a few of them, John. Thanks. Yeah.
Yeah, who should I introduce first? You or someone else or Mohammed?
So look, what will happen is myself and Mohammed will moderate the thing, and then I'll introduce between the two of us. We'll introduce Rick, Ted, and Martin Schumann between myself and Mohammed.
Okay, but who's the first guy I introduce? I'm going to introduce
Both
myself.
Yeah, no, you do that, and then just myself and Mohammed, and then we'll welcome the CAANS members, we'll welcome Nasser and all of that sort of thing, and then individually, because we've got such prominent speakers in Tad, Rick, and Martin, we'll introduce them kind of individually rather than broadly.
Yeah, I'll just introduce you, and you take it away, or whatever you want to do. Structure it as you want.
Great, okay.
And you can always communicate with me by texting.
Okay, beautiful.
You know, if there's a problem or something like that.
Okay, no, fantastic. Tad, you good?
I'm good. I cannot see myself. How about I say mute button? And do you see me? No, right?
I don't see you, but I can hear you, Tad.
So, that's nice.
You need to put your camera.
How about start the video?
Put your camera on.
There
There
you
you
go.
are. There you are.
There you go. Okay.
Yeah, I can see you now, Tad. Yeah.
Good to see you.
Doc, it's like a surgical instrument. When you first use it, you're a little rusty. You know what I mean? And then you get better and better and better.
It's not just a surgical
By
instrument.
then we have to retire.
Applies to, hey, John.
Yeah, well, it's my instrument. I better be good at it.
Okay.
I sent Rick a message now just to remind him as well.
Yeah, that's the Mohammed sent me the email just a minute ago and asked me to send him the short bio. So I mean, he's working on it, I guess.
Yeah. Okay, so John, I see Martin Schumann's joined as well. Why I asked Martin to join these webinars is because his CV is so short. It takes me hardly any time to introduce him. You know, he's done so little.
Oh, really? Just one
Are
line?
you, Martin? You're right.
Hi, I'm fine. Hello, everybody. Great to be here.
Hey, Martin.
Oh, there you are. You're taking some ribbing this
I
morning.
see you. This morning, you are noon now here in Chicago.
Yeah, we are an early evening.
Is it your house, your home?
Yeah, I just made it home. Yeah, I was.
Good.
Yeah, because it's dragging on later, so I just arrived.
Okay. I'm at my office.
Yeah, at noon. It's a privilege to be at home at noon, which we don't often have, huh?
Yeah.
We start in 10 minutes. So if you want to see yourself, go to the app, Neurosurgical TV. It's on the front page of the app. It's easy download.
I've got to still do that, John. I haven't done that.
Yeah, got nothing to do. Just register, and once you get it registered, you know how it works.
Yeah.
Oh, check the match. Oh, here's Mohammed.
Yeah.
Hi, everybody.
Hi, Mohammed.
Hi, John. Hi,
How you
Tad.
doing?
Hey,
Mohammed.
hello. Martin.
Hi, Mohammed. How are you?
Hi. Great to see you all.
Hey, did you get my email?
Yes, I did.
Mo, did you download the app already, the Neurosurgery TV app?
No.
Yeah, I'm
Should
just
I?
busy doing, I'm just busy doing that now as well.
You know, most people access it with a smartphone, more than like 60%.
And is that available in the App Store?
Yes, in both.
Just check it now.
Because
Yeah,
I couldn't
and-
find it under neurosurgical.
TV, it's neurosurgical space TV,
Okay.
or any variation thereof.
Okay,
But
got
it's,
it. Well, that's
and-
amazing.
Neurosurgical.tv.
well, it's easy because it's on the first page of the
Yeah,
app.
it is.
You start it right away. And you know, the beautiful thing about it, when you're watching on the fly, you can jump in. You can join the panel on your smartphone. And because yesterday we had a German neurosurgeon that just says, hey, I'm watching, I want to make a comment. He's watching from his smartphone. I think he was doing rounds. But he wanted to comment on something that was going on.
John, this is Rick Boop. Glad to join you.
Oh, hi, Rick.
Hi.
Hey, Rick.
Welcome, welcome.
Guys, Mohammed,
Hi. Hi.
Are you
How are
Rick? Right.
Good to see you.
Llewellyn?
Good. Worked pretty well. Hey, Rick. I mean, all things, eh?
Yeah, seems to be.
Yeah. Seems to be good. Yeah.
Okay, we got 5 minutes. Hello, Dr. Boop, Dr. Bennett, a neurosurgical TV.
What time of day is it there?
In Miami, it's 12:55,
Yeah,
1 o'clock p.m. Where are you at? You in London, England?
Memphis, Tennessee. An hour.
Oh, Memphis. Oh, you're about the same, right? Or a little central, right?
Yeah.
Yeah, we are here 7 p.m.
7
What is
p.m.
that, the neurosurgical TV station?
Thank you.
Where is that neurosurgical TV station?
Where? Oh.
Yeah, you know, we're doing some Japanese translation. We're starting to do them. We have a series with Dr. Lanzino of Mayo Clinic. He's starting once a month. Hello, Mahmoud. Yeah, I'll talk about that later. Hi, Mahmoud. How you doing?
Hi,
Welcome.
hi.
Welcome.
Hi, thank you. Hi, Martin.
Hi.
Hi, Moody.
Hi.
Hi, Tadanori. And Llewellyn, John's there.
Welcome.
You're
I
welcome.
saw a while ago.
Good stuff. Good stuff.
So,
We'll get a
Tad, what
couple
are you
minutes.
doing these days?
Hanging around.
Yeah.
Yeah,
You have one of my colleagues left here and joined you.
I know. He's a nice guy.
He's good. Good doctor.
Yeah. Hopefully his career will be great here, you know.
Moody, everything's good with you?
Yes, thank you very much, Rick. It's good to see you. Good to see you.
Likewise.
Yeah. What time is it there? 8 o'clock, 9 o'clock?
No, it's noon.
Oh, it's noon. All right.
Yeah.
It's coming to 8 o'clock in Nairobi here. Hi, Mohammed.
Hi, Moody.
Good to see you. Good to see you.
Good to see you.
Yeah.
And
Thanks
happy
for
feast.
organizing this. Llewellyn and Mohammed, it's great to have all you guys shine the light on pediatric neurosurgery for a change.
Yeah.
Appreciate the opportunity. One of my favorite topics.
Yeah.
So Mood, you guys an hour ahead of the rest of us already.
Yeah. You're at 7 o'clock, right?
Yeah.
Yeah, we're at 8. Yeah. Well, you're on Cairo time, so I think Mohammed and you are on the same time, right?
Yeah, that's
Yes.
Yeah, good.
Mohammed, your place must be busy these days.
Yeah, we're having, we used to have last week was a vacation because of the little feast. So the hospital was closed. And when we opened yesterday was the first day. We had like 19 new brain tumors first day.
Oh my
And
God.
today another 9, and yeah, a gush of brain tumors came at once. Yeah.
Unbelievable. Unbelievable. Yeah.
How's
Mohammed, how many people in your group? I was a couple of years ago, but I can remember how many the staff.
The staff we have now, me and another 4 who are seniors, also consultants, and the assistants are 24. So all in all, around 20 now. The staff.
It's a big group.
Yeah.
Yes.
Okay, 1 minute, we start.
Let me know when you want me to share my screen.
Oh, not yet, please. While we introduce people, I'd like to see their face. So just
Sure.
hold on with the sharing,
Okay.
okay? Otherwise, people meet someone in a little profile picture. Can't see. Okay. Get some last minute arrivals just letting in.
Hi, John, you must be very busy, huh? You must be going.
It's like you guys, you like something and time just goes by, it just flies by. Okay, we're ready to start. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good afternoon from Miami Beach. It's Dr. John Bennett of Neurosurgical TV. It's an honor to be hosting the CAANS, Pediatric Neurosurgery webinar series, and I'll introduce Llewellyn Padayachi to start the proceedings. Welcome, Llewellyn.
Hi, John. Thanks so much. Firstly, this sort of webinar series is run by Mohammed Al-Baltaghi and myself in conjunction with CAANS, and we're privileged to have the president of CAANS joining us as well, Professor Mahmoud Qureshi. So this, I think, is our 5th rendition of pediatric neurosurgery, the 3rd in the pediatric brain tumor module, and we're incredibly privileged to have with us today 3 incredibly prominent speakers. And just out of respect for their tremendous international profile, we'll introduce them individually. So our first speaker is Professor Rick Boop, and then we've got Professor Ted Tomita, whom Mohammed Al-Baltaghi will present, and then it's Martin Schumann who will close off for us. Mohammed, any comments quickly before I introduce Professor Boop?
Just it's our first time to have this with John, streaming our webinars. We hope that it reaches everybody until we have our own channel. And thanks for the faculties accepting the invitation to help promoting these webinars in Africa, among the pediatric neurosurgeons in Africa especially. And thanks for, and of course, Woody Qureshi, the president of CAANS, if you want to add something.
Thanks, Llewellyn and Mohammed. Thank you for giving me the opportunity to be part of this. from the CAANS perspective, the Continental Association of African Neurosurgical Societies, it's an absolute privilege to have the galaxy of stars across the globe join us. And really, Tadanori, Rick Boob, and Martin, thank you very much for honoring CAANS with your presence. And I'm sure the participants are going to have a feast of a time listening to you folks. So thank you very much on behalf of the Continental Association. We're proud and privileged to be hosting you. And once again, Llewellyn and Mohammed, you're doing us proud, really. You know, there's been lots of webinars, but they've been concentrating essentially on the adult population, and 50 to 60% of our population across Africa is pediatrics. And I think you're doing justice to that. Thank you very much once again, everyone, for being part of this webinar. Over to you, Llewellyn.
Thanks so much. Thanks so much, Moody. Thanks for joining us. Thanks for making the time. And Mohammed, you're absolutely correct. Thanks to John Bennett for all the effort he's made in distributing and doing the flyers. It's really been a privilege, doing this together with John. So our first speaker, there can be no, I think, greater privilege in pediatric neurosurgery at the moment than introducing somebody the stature of Rick Boob. And talking on ependymomas, I'm not sure there are many people in the world who know much more about ependymomas than Rick does. So just briefly, Rick is chairman and professor of neurosurgery at the University of Tennessee. He's the chief of pediatric neurosurgery at St. Jude Children's Research Hospital. He is currently the president-elect of the ISPN, and that's just a sort of temporal evolution thing. It would have been president were it not for the sort of COVID-19 perspective. He's also past president of the AANS, and these are just a few amongst these many accolades and positions. And I think they just underscore his widely respected standing as one of the leading international figures in pediatric brain tumor surgery in the world. So Rick, I think with that, I'm going to hand over to you to get started with your talk. Thanks so much, Rick, if you want to share your screen.
Thank you, Llewellyn, Mohammed, Moody. It's a tremendous honor today. Let me see if I can share my screen and bring up these slides, and I'll share with you some thoughts on the subject. Can you guys see my slides?
Yes.
All right. So I'm very fortunate in my position at St. Jude to have a central referral of a number of children with ependymomas and also a group of basic scientists who've done a tremendous amount of work in the field of ependymomas. And I'd like to share with you some thoughts today. And I wanted to start with this case because this is an interesting case. This is a 3-year-old that came a few years back, presented to the emergency room like this. Episthetonic, wide awake, stable vital signs, but the family said he'd been this way for 3 days, and they'd actually had him in our emergency room 3 weeks before this, complaining of back pain, and the emergency physicians had done x-rays that were normal and sent them out. But they didn't mention in their note that he had torticollis at the time. So he had a CT scan that night that demonstrated this posterior fossa that's just solid tumor. If you look at the craniocervical junction here, there's no subarachnoid space at the craniocervical junction, acute hydrocephalus. And the question is, how do we manage this child? Is it safe to sedate him for an MRI scan? Is it safe to straighten him out and flex his chin forward to do the MRI, much less position him chin to chest to do a suboccipital craniotomy to take this tumor out? And I'll let you think about that while I give you some thoughts on ependymomas. So remember that ependymoma is the 3rd most common brain tumor in childhood, and it makes up about 10% of our total. So when we look at the pie chart, the supratentorial tumors are here, infratentorial tumors are here, ependymoma is in the blue, but as you know, they can occur in the brain and the spine as well. And they really are a neurosurgeon's tumor in that although they're a cancer, 90% of them are localized at presentation. It's unusual for them to have metastasis at presentation. And so that gives us the opportunity as surgeons to have a great role in the opportunity to cure this disease. 2/3 in children are infratentorial. And when we look at outcomes historically, these tumors have had a dismal 5-year progression-free survival, less than 50%, overall survival about 50%. And keep in mind that even with surgery, the median time to progression is on the order of 2 years. So they can recur fairly quickly. Typically, when they recur, most commonly it's going to be a local recurrence, but they can recur with distal metastases. And generally, we've also proven over the years that ependymoma, for most of us, for most patients, is a radiation-sensitive tumor. This is a paper that Tom Merchant published just over a decade ago in 2009. At that time, we had 153 ependymomas in our series, just showing that with aggressive surgery followed by focal radiation therapy, the vast majority of these children could enjoy good local control and over 70% event-free survival. But this is one tumor where the difference between a gross total resection and anything less than that is significant. When we look at conventional chemotherapy for ependymomas, they really have had a troubled role. And as Michael Taylor has told us, there's not a conventional chemotherapy regimen that has been proven to prolong overall survival in children with ependymoma. When we look at older studies, even back into the 90s, no improvement compared to radiation alone in overall survival. Even in the baby POG studies in the infants less than 3, what we found was that delaying radiation by giving chemotherapy increased the risk of recurrence for these children. So we use chemotherapy nowadays in young infants with vascular tumors to decrease the vascularity, but otherwise it's not been a part of our conventional treatment of ependymomas. These are results of our RT1 study, which is one of the first prospective controlled trials we had with resection followed by 3D conformal radiation. And what we learned from that trial is that the 4 factors that predicted survival were: number 1, extent of resection, and the difference between a gross total resection and anything less than that is significant. Tumor grade, the anaplastics tended not to do as well as the differentiated ependymomas. Age, and remember that the younger children tend to be the ones to get the anaplastic ependymomas, so there's some overlap there. And then pre-irradiation chemotherapy, delaying radiation treatment to the focal tumor bed did not have as good an outcome as the kids who went straight on to radiation therapy after surgery. So when we look at pathology, historically, we've had differentiated, we've had the anaplastic, and we've had trouble deciding what to do when we've got a tumor that's got some anaplasia within it. And just a comment on the myxopapillary ependymomas, because currently they're listed as a WHO grade 1 tumor. And historically, we felt that in adults, if they presented with a myxopapillary ependymoma and it was resected, they were cured. In children, the biology of this tumor is not the same. It's not uncommon for the children to present with metastases. And when they do, since it's subarachnoid metastases, then we're talking about craniospinal radiation for treatment. This is a picture of a surgical video of a young adult with a myxopapillary ependymoma showing how we like to treat them. This gentleman had a 2-year history of pain referred to as hips and legs, and had had 2 arthroscopic hip surgeries by the orthopedic surgeons, which were non-helpful to him, and eventually got to the point that if he coughed or sneezed, he felt like he was going to die. Focal tumor here at the filum, typical imaging characteristics of myxopapillary ependymoma. Enhancing tumor, no evidence of metastatic disease. And so in this case, we want to do a laminoplasty. You see us opening the dura here. And I'm going to breeze through this, leaving the arachnoid intact. When we open the arachnoid, we clip the arachnoid to the dura so that when we close the dura, we're also closing the arachnoid and restoring the subarachnoid space. And you can see the wet clips as we open this, clipping the arachnoid, tumor coming into the view underneath. And here you can see the filum terminale and the tumor. These tumors have been reported to grow down the inside of the filum, so we want to cut the filum as distal as we can from the tumor, leaving the tumor capsule intact and trying not to spill any tumor. Then once we've cut the filum, we can use that to elevate the tumor within its capsule, dissect it away from the underlying nerve roots. And typically the vascular supply to these tumors will be from 1 or 2 radicular vessels coming in along with the nerve roots. So once we identify the radical, you can see the radicular artery here feeding the tumor, and it's fairly simple to coagulate and cut that. But again, we want to do that outside the tumor capsule. Here we're stimulating to make sure that these nerve roots involved are sensory, not motor. And then you can see here also a blending of the tumor with the end of the spinal cord. And we've stimulated there as well. So here we've coagulated and cut the radicular artery. Then stimulating the distal spinal cord with electrodes in the anal sphincter and not getting any response there. We felt like we were comfortable coagulating and cutting that. Sorry about that. Let's get back to that. And then lifting the tumor out on block and trying not to spill tumor. If we spill tumor, then that's when we worry about subarachnoid spread and potential recurrence within the cauda equina most commonly. Once we take the tumor out, then we inspect for metastasis, try not to leave any gel foam or foreign material within the thecal sac, and then go ahead and close the dura. And as we do, we'll close the arachnoid in a single layer. My personal preference for closing dura is a Gore-Tex, 7/0 Gore-Tex suture, which is easy to sew, and we take the wet clips out as we go. So this is a paper from Mark Bilski at Memorial Sloan Kettering in adults with myxopapillary ependymomas, reviewing his experience. And 20% of those patients had metastatic disease at the time of presentation. Another 10 to 15% developed recurrence with metastasis in the cauda equina. And he's also posing the question that this is not behaving as a grade 1 tumor, even though WHO has called it that. And indeed, I'm told that in their newest iteration of the WHO tumor classification, myxopapillary ependymomas will be listed as a grade 2 tumor and not a grade 1 tumor. When we think about what neuropathologists see under the microscope, even with central review of tumor specimens sent in from our multi-center prospective national trials, the level of agreement between the experts in the field varies by 15 to 20%, showing that when we look under the microscope, even though something looks like a ependymoma, we know that the biology of a posterior fossa ependymoma, supratentorial ependymoma, spinal ependymoma is very different from one location to the next, even though they may look the same under the microscope. When Michael Taylor was our fellow back in 2004, he worked in Richard Gilbertson's lab to conduct studies where they looked at the gene chip arrays of a variety of ependymomas. These are supratentorial, these are spinal, and these are posterior fossa, and showed quite clearly that the genome of these ependymomas was quite different based upon anatomic location, and that not all ependymomas that look the same under the microscope are the same molecularly. And this was confirmed, as you see here, by tissue microarray. They also went on to do studies looking at what the cancer stem cell might be for ependymomas, and their studies would suggest that the radial glial cell is the precursor cell to ependymomas. This is a study also done out of St. Jude where they took the driver mutations for the human ependymoma and were able to manipulate orthotopic genes in the mouse and grow cancer stem cell clusters in the petri dish and in the mice that recapitulated the humans, not only histologically, but also molecularly, so that we now have good mouse models of the human ependymomas. This is a nice paper that the Sick Kids group went on to produce in conjunction with Stefan Pfister's group in Heidelberg. And to me, this is a neurosurgical classic. Initially, they made the point that amongst posterior fossa tumors, the tumors that grew in the CP angle were different than the tumors that occurred in the fourth ventricle. And they termed these PFA versus PFB. They've gone on to show that even though they look the same under the microscope, that biologically, they're very different tumors. The PFA tumors tend to occur in infants, and they're more likely to be lateral out in the cerebellopontine angle. They're more likely to invade brain, recur, metastasize, and cause death than are the PFB tumors that tend to occur in teenagers and older children. And they looked at the molecular difference between these, and we now know that whereas the group B tumors have typical chromosomal instability of cancer, the PFA tumors have very little genetic instability, but are probably different because of epigenetic phenomenon. And we'll talk more about that in a bit. But suffice to say that in this paper, they describe immunohistochemical differences between the two groups so that you don't have to have sophisticated gene chip arrays to tell the difference between these tumors, but that there is a difference in the prognosis and the behavior of these tumors. One of the big signatures for us in terms of prognosis for ependymomas is gain in chromosome 1. And you can see that this can be done by FISH on paraffin-embedded blocks, so you don't have to have fresh tumor samples to do that. But tumors that have a chromosome 1 gain are biologically more likely to recur and more difficult to treat than are the tumors without chromosome 1 gain. And you can see in our group here, looking at posterior fossa ependymomas, the difference in the survival of the kids who have no chromosome 1 gain versus the ones who do. So this is a standard part of our pathological analysis for posterior fossa ependymomas nowadays. So in our current iterations, we recognize 9 different subgroups of ependymomas. We have 3 supratentorial ependymomas, the Raleigh fused, the YAP1 tumors, and then the subependymomas. We have 3 different subtypes of posterior fossa tumors, the PFA, PFB, and subependymomas. And then the spinal ependymomas, we have the myxopapillaries, and then the tumors that occur within the spinal cord. We know that for the Raleigh fused tumors that there's probably a C11orf95 fusion that drives the mutation of these tumors, and they're commonly in the supratentorial space. This is a paper from Stefan, from the Heidelberg group showing that the Raleigh fused patients don't do nearly as well in the as compared to the YAP tumors in the supratentorial realm. We've not been able to recapitulate that in our own data. In fact, in our series, the YAP tumors and the Raleigh fused tumors do about the same. So here's a picture of an infant who presented with typical symptoms of raised intracranial pressure, had this cystic and solid frontal lobe tumor, as you see here. With contrast enhancement, you can see quite well enhancement of the cyst wall, which tells us that this is a neoplastic lining and that it has to be resected along with the tumor because it's ependymoma. And this is an approach down the interhemispheric fissure to expose this tumor. You can see the tumor capsule here adjacent to the falx, and you can see us dissecting that tumor capsule away from the normal brain next to it. And then in this case, that capsule was fairly fibrous, so we're able to grasp it and manipulate it and dissect it away from the normal adjacent brain, keeping the capsule intact as we work to debulk the tumor, dissect it away from the brain. I'll skip through here in the interest of time, but eventually working around the tumor, separating that neoplastic capsule from the adjacent white matter until we can get a clean resection and get the whole tumor out. And in this case, this was a Raleigh fused tumor, and based on that, even though the child was 3 years old, we gave focal conformal radiation to the tumor bed, and she's not had any recurrence. So in terms of molecular subgrouping, this is looking at our young children. These are 3 years of age and less with ependymoma. We've had 54 kids in the series where we did give upfront chemotherapy and then radiation therapy. And again, despite all of our perturbations at the end of the day, it's the extent of resection that determines the outcome in these kids. And the kids who had a gross total resection, we had 89% survival compared to significantly less in the kids with anything less than a gross total resection. So in our series, we will take children back to surgery to get residual disease. If it's stuck to critical structures like an important blood vessel or cranial nerve, we will debulk and leave a millimeter piece behind, or certainly a few millimeters at best, in order to try to get as near total resection as we possibly can. If they invade the floor of the fourth ventricle, we'll try to get down to a thin carpet before we resect, before we give focal radiation. And this is just further work from the Sick Kids and German group in collaboration, looking at the molecular genetics and showing that it's probably epigenetic phenomenon that drive the malignant characteristics of the PFA tumors. So going back to our index case here, here's the child in our OR on the intraoperative MRI table. Our decision was to put him to sleep and leaving his blood pressure normal, place a ventriculostomy, judiciously drain fluid to lower the intracranial pressure, and then turn him prone, get him into position in our intraoperative MRI suite. And you can see with his vital signs stable, ventriculostomy in place. Here's his tumor growing down to C3, growing out the foramina of Luschka on either side, and filling the fourth ventricle. You can see the craniocervical junction here is just compressing is compressed by tumor. And so here's surgery starting at the C3 level, peeling the tumor away from the spinal cord, leaving the PIA intact, cutting dentate ligaments if we need to, cutting the occasional dorsal rootlet if we need to, then working up top to separate the tumor from the cerebellum, as you see here. And as we see the floor of the fourth ventricle early on, looking to see if the tumor is invasive. Usually these are not. Usually these arise from lateral rests along the rhombic lip and don't invade the floor of the fourth ventricle. Then debulking tumor with the ultrasonic aspirator. These tumors will all derive their blood supply from the vermian branches of pica. So identifying those early on, we can identify the feeding vessels to the tumor and divide those, devascularizing the tumor. As we get into the fourth ventricle, early on, putting gel foam over the aqueduct so that we don't spill tumor. And once we've debulked the tumor from the spinal cord and the fourth ventricle, then looking out amongst the nerve roots into the CP angle for tumor out at that level and taking it there as well. And you see here, once we're done, we have a little bit of residual along the vermian branch of pica on this side that we're going to take out. Then leaving no gel foam, no Surgicel, no packing material, making sure we've got all the tumor out. And here's his intraoperative MRI post-op showing a clean resection of that tumor, no significant residual. Here he is in the clinic 2 weeks later. He's got my reflex hammer and says he wants to be a neurosurgeon when he grows up so he can hit people with a hammer. And he's done quite well. So you can see from this picture that these can be daunting tumors. This is a CP angle ependymoma encasing the basilar artery, growing out the skull base foramina, compressing the brainstem, rotating the floor of the fourth ventricle, and encasing both the vessels and the nerves. And these can be challenging cases. We'll usually approach these through a hockey stick incision, positioning the patient's chin to chest, but then turning their chin to the ipsilateral of shoulder so that we can work either from a retrosigmoid or a midline interhemispheric approach as we go. We use the forehand technique with two opposing surgeons working across from one another, four hands in the field. And I'll show this quickly. This is a patient that had an extensive tumor growing out foramina of Luschka on both sides, encasing the brainstem, growing all the way around in front to the basilar artery. And again, starting down low, opening the arachnoid, trying to keep the tumor capsule intact as long as we can, working up to the cranial cervical junction, debulking with the ultrasonic aspirator as we need to, taking the blood supply from the tumor and trying to separate the tumor sharply from the cranial nerves rather than using blunt dissection. As we work here, debulking and then working between the cranial nerves to try to keep the nerves intact, but to minimize the manipulation, particularly of the 9th and 10th nerves. In these young children, it doesn't take much manipulation for them to wake up with vocal cord paralysis and to need a trach or a G-tube. When we started doing these 20 years ago, we had a 30% incidence of trach and G-tube with these resections. In the last 5 years, we've only had one child that had to have a tracheostomy, and that was for Ondine's curse post-operatively, a central sleep apnea that persisted. But in general, we're aggressive with these. We're able to get these out as long as we take our time and treat the cranial nerves kindly, as you can see here. So instead of doing blunt dissection, we'll separate the fibers of the 9-10 complex sharply and try to take the tumor away from the nerves and not the nerves away from the tumor. And you'll see here, once we've completed it, here's our post-op scan. Not the best imaging, but showing a good clean resection, and then focal conformal radiation to the posterior fossa after that. So this is, again, a compendium of patients from a number of different centers published by Michael Taylor's group with David Ellison, our neuropathologist, 820 posterior fossa tumors. And the take-home message is if it's a PFA, anything less than a gross total resection is not going to be curative to these children, and they need a good resection even if it takes multiple attempts. So here's our current nomenclature for these, the supraintorial ependymomas, as you see, the PFA, PFB, subependymomas in the posterior fossa, and then the spinal ependymomas. And this is a paper from David Ellison and our group at St. Jude, where they've gone on to subdivide the PFA tumors into two major subgroups and 9 minor subtypes based upon the molecular profiling of these tumors. Again, we may be talking about lumpers versus splitters, but there are clear demographic differences between the two groups, and there are clear molecular differences and differences in the biology of the two groups, with some of these being highly curable and some of these portending a much poorer prognosis. Here's the one gain, 6Q loss, 10Q loss, etc. And so finally, I'll just show this. This is a teenager whose dad was a family practitioner. She came to us with dizziness and was found to have this focal tumor just at the obex, invading the floor of the fourth ventricle, as you see here. And this is her resection. There are the tonsils. This is top of the head. This is the spinal cord. You can see the tumor under the arachnoid here. And we began again protecting the floor of the fourth, looking early on, identifying that it's invading the floor of the fourth, and then manipulating, trying to minimize the manipulation of the tumor where it's stuck to the floor, lest we harm the floor of the fourth ventricle. Debulking the tumor, as you see here, putting gel foam below so that we don't cause iatrogenic spread of tumor, and then debulking, working around the tumor. And then the last thing that we want to do is address where the tumor invades the floor of the fourth ventricle, covering the aqueduct so that we don't cause iatrogenic spread up the aqueduct. And here you see where the tumor is starting to invade the floor, and we'll debulk this with the ultrasonic aspirator and then very carefully try to dissect it off of the floor of the fourth ventricle. And instead of bipolaring on the floor of the fourth, we'll put gel foam there and minimize the heat to the floor of the fourth. And she woke up neurologically intact, but her tumor came back a grade 3 anaplastic ependymoma, no 1Q gain, but diffuse H3K27M immunoreactivity, which you know is the histone mutation that signifies a midline glioma and portends a poor prognosis. And we've had 3 or 4 ependymomas now, typically in teenagers, typically invading the floor of the fourth ventricle at the obex, that have this H3K mutation associated with them. So far, with focal radiation and a good resection, they've all been surviving. So in conclusion, the majority of these childhood ependymomas, the extent of surgical resection, what we do as neurosurgeons, is the most important predictor of survival and outcome. In infants with very vascular tumors, a round or 2 of chemotherapy can dramatically reduce the bleeding and facilitate second look surgery such that we can get a good resection without having to worry about exsanguinating these babies. Being familiar with the various tumor subtypes is critical as we approach them. And families should be counseled preoperatively that if the post-op MRI shows significant tumor residual, this should prompt a return to the OR for further tumor resection whenever possible. So thanks once again for allowing me to be with you today, and I appreciate the opportunity to give you my thoughts on this topic.
So thanks, Rick. As usual, that was an absolute masterclass on the topic, and I think the kind of what people have learned is profound. I think before I ask some questions myself, John, do we have any questions that have been posted?
Yeah, yes, there's one from Dr. Uday. Dr. Uday Gupta from India. Do you want to ask that directly, or do you want me to read it? Perhaps he doesn't. He says, I want to ask whether neuromonitoring is used during post-fossa resections.
Good evening, sir.
Yes, we generally will, particularly for the CP angle tumors. We'll monitor SSEPs, brainstem evoked potentials, motor evoked potentials, and have 7th and 8th neuromonitoring. Probably the most critical thing to monitor is 9th and 10th nerve function, but as you know, that requires monitoring electrodes on an endotracheal tube, and in the pediatric population, you'd have to have a different size tube for every child. So that turns out not to be practical. We have sometimes put needle electrodes into the palate and monitored 9 and 10 that way, but you have to put them in with the patient supine and then not have them fall out when you turn the patients prone and position them. So yes, we do use it. For the spinal ependymomas, we use spinal cord monitoring as you would with D waves, et cetera. And I think it's useful, but it still requires that we try to get all the tumor out whenever we can.
Thank you.
Thanks, Rick. I'm going to ask one of the other panelists, maybe Mohammed, any questions or comments at the moment?
Thanks, Rick, for this very interesting presentation and wonderful videos. Actually, very difficult tumors. I'm just wondering, what is the youngest age you're giving radiotherapy for? And if proton therapy is do you have any experience with proton therapy if it's superior to the conventional or gamma knife in case of ependymoma?
Yeah, we've been doing proton beam for 3 or 4 years now. Before that, we had 3D conformal radiation, and we've radiated kids, given focal radiation to the posterior fossa down to a year of age with good success, with a 5 millimeter surround of the GTV, gross tumor volume. We think that our results with the proton beam are going to be better in terms of side effects than they were with 3D conformal. The treatment volume is significantly less, and we think there will be an inherent advantage, particularly in younger kids, but that data is not published yet.
Yeah. Great, thank you.
Okay, we've got a hand up there. I can't see who that is, but maybe Laura Science, do you want to unmute yourself and ask a question, Laura?
Oh, thank you very much for your talk. I was just wondering, what is your thoughts on the management of single metastasis, spinal metastasis, for example, posterior fossa ependymoma? So what is your first approach on this?
Right. Well, as I mentioned at the beginning, most of the time when they recur, they'll recur in field, but when they recur metastatic, that's problematic. So if you look at the history of salvage chemotherapy for ependymomas, the survival is on the order of 15%. It's very poor. And based on that, years ago, we started looking at re-irradiating children that have recurrent ependymoma. And we now have a fairly large series where Tom Merchant has given re-irradiation if it's been at least a year since they had prior radiation. If it's a focal infield recurrence, re-irradiating the area that had been previously, but if it's metastatic disease, giving craniospinal radiation. And our survival rate for those children that have had craniospinal radiation, and let me be clear that when we do this, we will try to resect any large metastases and radiate small bits of residual. If they have one met, we'll resect that and give craniospinal radiation. And we've got about 35% 5-year survival in the kids, and they seem to be tolerating it fairly well. Less than 10% of them have had radiation necrosis.
Yeah, thank you. I cannot say as your patients, but I can say thank you for teaching me.
Well, thank you for the opportunity. I wish I could stay for the other talks, but I'm in the middle of clinic, so I'm going to have to run shortly.
Okay, just before you disappear, Rick, maybe a slightly unfair question, I know, but you know, with ependymomas, like you've pointed out, gross total resection is key. But if we could just broaden that maybe a little bit, you know, with the interest in radiological biomarkers and their predictor of kind of biological mark, are there any features that you would see or would make you do less, you know, make your approach a lot less aggressive, you know, just biopsy and, you know, preemptively decide that this is, you know, not resected?
Yeah, not for ependymomas so far. I know with medulloblastomas, if it's a Wnt tumor, we're comfortable being less aggressive surgically and more aggressive with radiation chemotherapy. But I've not seen anything amongst the ependymomas so far that makes me think we can get away with subtotal resection. Our feeling is that radiation and chemotherapy do very well at cleaning up microscopic residual, but they don't do very well at curing lumpy disease. And so if we have lumpy disease, then we'll try to address that surgically. Early on in our RT1 series, we thought that our near total resections were going to stratify with our gross total resections. We defined near total resection as less than 1.5 cc's residual. And at 5 years, we found that the near total resection stratified with the subtotal resections and not with the gross total resections. So that caused us to be more aggressive rather than less aggressive.
No, thanks, Rick. That's incredibly useful. Just before we sort of say goodbye to you, is there any of the other panelists or faculty, Ted or Martin, perhaps, who have any questions?
Yeah, there's one quick question before the doc goes to clinic, and thanks for your time. Dr. Fahad asks, is there a subtype of P. Fossa ependymoma that does not need radiotherapy after GTR, or do you irradiate all of them?
No, the rare subependymoma, we do not radiate. If we get a gross total resection, we feel like they're surgically cured. But the PFAs and the PFBs, we've given focal radiation to.
Thank you.
Rick, thank you very much. Great talk. In regards to mixed papillary ependymoma, and you did a great job to the unblocked resection of the tumor versus those patients present with a ruptured mixed papillary ependymoma in the spine. The grossly resected with intact capsule, do you give radiation to those patients?
If they have residual disease or if they have metastatic disease, we do, Tad. And so if they present with metastatic disease or they come back with mets, usually it's in the cauda equina. And we've given focal radiation up to about the epiconus. But then and again, we'll get an MRI before we treat to make sure they don't have mets in the brain or mets higher up. Those patients would get craniospinal radiation. The problem is when they recur, if there's any overlap in the middle of the spinal cord where you're going to give double dose to the spinal cord, it makes us very nervous. Yeah. But on the other hand, craniospinal is so morbid. If we can just treat the cauda equina, we have. So
how about the unblocked resection? Do you give radiation? I always oppose that, but no. These days, oncologists has a much stronger say than used to be.
If we do an unblocked resection like the case I showed, we don't give radiation.
Right.
Yeah. But if it invades the spinal cord, if it extends up intramedullary, if we worry about any microscopic residual, we'll get focal radiation.
Yeah.
I assume you do the same.
Martin, I see you've got a hand up.
Yeah, Rick, thank you very much for this excellent educating lecture. Maybe you can comment on the critical things. One was the need and the urgency for reoperation prior to chemotherapy or radiation. I mean, nicely demonstrated that the arachnite is our best friend in these type of surgeries, and it's never so easy to get it out of the cranial nerves or alongside the brainstem than in your first attempt when the arachnite is still intact and not scarred as we see it after previous surgery or after radiation therapy. So we're trying to establish panels to encourage people to do reoperation prior to anything else. Maybe you can also comment on your experiences with the planes and the dissection and the chances to harm the critical structures. And the second question is, what are your actually real limits from the surgical point of view? In my opinion, these tumors going very ventrally, going around the basilar artery where you have the problems with the little perforating vessels to the brainstem, or these tumors extending far up to the tentorial notch. Maybe you can give from your vast experience, tell us where are your personal limits in gross total resection.
Sure. Well, I think you make a good point in that your first surgery is your best opportunity for a gross total resection. At that point, the arachnoidal planes will often allow the tumor to be removed either with microdissection or with the CUSA. Even if it's under the spinal cord, we can often fish it out. I share the places I've left tumor behind are in the basilar perforators or where tumors grown out the internal the porus acousticus. Ependymomas love to grow out skull-based foramina, and I've typically not chased them very far if they do that. Interestingly, if you've got a clean resection and you have a recurrence of ependymoma, John Jane made this comment to me one time when I was lecturing at UVA that recurrent ependymoma is one of the few tumors that's easier to remove than the primary. But you're right, your dissection planes are only preserved on your first operation. The other place for the CP angle ependymomas is they tend to arise from the lateral aspect of the belly of the pons just outside the foramen of Lischka, and they're quite stuck to the pia. They derive their blood supply from the pontine pia there, and it's important to try to spare any of the brainstem perforators that you can as you take the tumors off.
Okay, Rick, thanks so much for taking time out of your day. It was a really spectacular talk, and look forward to catching up again soon.
Yeah, the honor's mine. Thank you for the invitation.
You're welcome.
Cheers.
Mohammed, I'm going to hand over to you then to introduce our next speaker.
Okay, and thank you, Rick, again. And now we move to the second speaker, talking about germ cell tumors in children with Professor Tad Tomita. Actually, Tad is a great friend and is a giant professor in neurosurgery in pediatric field. He's currently a eager professor and director of Falk Brain Tumor Center and Robert Lurie Children's Hospital, professor Department of Neurological Surgery at the Northwestern University Feinberg School of Medicine in Chicago, Illinois. The education and degrees Professor Tomita had started in 1966 in the medical school at Kobe University in Japan, and his residency was at the International Hospital in Northwestern University McGough Medical Center in Chicago, in Illinois. Professor Tomita worked as an associate professor of surgery at the Northwestern University, and he has been the division head of pediatric neurosurgery and vice chair of the Department of Neurosurgery at the Northwestern University Feinberg School of Medicine from 2001 till 2019. Professor Tomita had over 265 original articles in referred journal and 46 books and chapters. And the committee membership, he has been the co-chair of the ISPNO and the ISPN Education Committee chair from 2006 till 2010, and the ISPN president from 2011 till 2012, and now an ISPN historian. Also, Professor Tomita had been an editorial board member in the Pediatric Brain Tumors, editor-in-chief in the Journal of Neurosurgery Imaging and Techniques, an editor-in-chief in Neuroscience Discovery, and associate editor in the Child's Nervous System. So Tad is very well known and one of the giants who have paved the way for many pediatric neurosurgeons in the field. And I guess we will have great experience from listening to his interesting lecture about germ cell. Please, Tad, can you share your screen? Yeah.
There you go. It's come out? No?
Not yet. Take your time.
Or maybe share. Or that. Here you go.
There you go. There you go. All right.
Oops.
Perfect.
Thank you so much, Mohammed, inviting me to this wonderful opportunity. And I'm talking about this germ cell tumor. Germ cells are biological cells that give rise to the gametes, the future sperm and ova. But we don't know why it happens in the brain. And just briefly, histogenesis is very important to understand what's going on. So-called primordial germ cells originate in the posterior epiblast in the pre-gastration, the embryos, invading through the hypoblast and reach to the yolk sac at the 3rd to 6 weeks of gestation. And then they migrate from the fetal yolk sac through the dorsal mesentery of the hindgut to the gonad ridge, and there it starts to proliferate. There subsequently it stops. And then the primitive yolk sac also recedes. Now, migration of these germ cells, there's a couple of theories. Probably they go through blood-borne, through the newly formed blood vessel, and extravasate at the genital ridge, or along the sympathetic nerve fibers toward the genital ridge. And now, brain supposed not to have this kind of germ cells. Now, why it happens? Perhaps still we are not sure the real mechanism. So, extragonadal germ cell migration may be a failure of the primordial germ cells to exit or stop at gonadal ridge and further extend to retroperitoneum or mediastinum, particularly to the thymus, and then further up to the brain. Or maybe downward, mismigrated primordial, the germ cells can extend to sacrococcygeal location. And those cells usually undergo apoptosis and go away, but some maybe stays quiescence condition. And now when the time arrives, particularly at puberty, the puberty is that the gonadotropin or gonadotropin release hormone become activated, and then those cells may wake up and start to act badly. Now, when you look at germ cell tumors, there's two main different types. One is germinoma, and another one is non-germinoma, that's germ cell tumors. And the embryonic cell carcinoma, yolk sac tumor, choreocarcinoma, teratoma, and the mixed germ cell tumors, they are the subclassification of the so-called germ cell tumors. So histogenesis, Taylor published this article in 1954. Probably that is a transformation of primordial germ cells that become the germ cell tumor. Another more recent theories are a stem cell theory. Probably embryonal stem cells are the origin of the germ cell tumors. Now, when you look at the molecular landscapes, particularly epigenetic investigation have been done, and germinoma is very likely to originate directly from primordial germ cells. On the other hand, non-germinomatous germ cell tumors usually take place from pluripotential embryonal stem cells in the brain that likely endogenous neural stem cells, and they are the likely origin of primary CNS germ cell tumors. The embryonal carcinoma, which is essentially a counterpart of embryonic stem cells, and this should be the prototype of all non-germinoma germ cell tumors. And that they then differentiate to yolk sac tumor or choreocarcinoma or teratomas. Now this is the summarized histogenesis of the germ cell tumors. primordial germ cells, probably the direct cause of germinoma, and the embryonal stem cell, the primary provide origin of embryonal carcinoma, and then extra embryonal tissue differentiation toward toroblast would become the choriocarcinoma, yolk sac to the endodermal sinus tumor, and the embryonal tissues, ectoderm or endoderm or mesoderm, become the source of the teratomas. Now, it's quite interesting when you look at the histological feature to explain the types of the germ cell tumors. For instance, germinoma. This is large cells and so-called small T cells that present with the two cell patterns. And when you look at the large cells, that is a resembling of primordial germ cells indeed. Now, mature teratoma is three more well-differentiated elements of three germ layers: ectoderm, mesoderm, and endoderm. In a very rare occasion, we see a more advanced organogenesis in the tumor, and this could be a fetus in fetu. Willis in 1935, he theorized twinning theory. That means parasitic twin, and another mechanism may be highly differentiating teratoma. Now, mature teratoma, for instance, this 11-year-old boy presented with typical headaches and emesis, and there's a quite heterogeneous appearing CT findings, and you can see hyperdense to hypodense appearance, and this is MR. This patient had EBD and at the same time endoscopic biopsy, which showed keratin debris and histiocyte and giant cells. Now you can see when you look at very carefully, there's already some rupture of the membrane, and it's turned out to be the keratin debris. And this tumor was resected, and pathology showed fibroconnective tissue and skin and mature cartilage and fatty tissue, and also intestinal and respiratory type tissue. And this is a benign mature teratoma. Other patient, this one, I had this 20 years ago. This is a 3-year-old girl with a visual loss and quite a large tumor. This is CAT scans, hypo and hyperdensity, and large cyst formation. And I resected this tumor. It's turned to be a line of the teeth is sitting. Probably these are the multiple teeth. So this could be a mature teratoma with organogenesis. And this indeed had a much larger cavity I created after tumor resection. And this patient did not have any further recurrence over past 20 years. Now, how about immature teratoma? Often it's present within a mature teratoma, and they are incompletely differentiated or embryonal component, resembling a fetal tissue. Most common histological immaturity occur among the primitive neuroectodermal elements. So you can see the rosettes or a neural tube formation and so on. And some area, the embryonic mesenchyme, which has hypercellularity and also mitosis. So this is not necessarily a bad tumor, the essentially very primitive component within mature teratomas. On the other hand, some teratoma can transform to malignancy. I think somebody's talking. Now, immature teratoma, for instance, this is a 20-month-old baby boy with emesis for 3 weeks, and this is hydrocephalus, a large tumor. ETB showed negative for HCG, yet serum AFP is elevated, and this was resected, and nice resection undertaken. And the pathology showed mature teratoma with derivatives of endodermal forming the intestine-like structure. That is probably the very likely the cause of elevated AFP. Nothing's the cancer's component. So immature component resembling the neural tube within that. But about a year later, the patient had radiographic evidence of the recurrence, very small cyst formation in the third ventricle. This turned out to be a mature teratoma. And this patient, since then, over 4 years, did not have any evidence of recurrence without any adjuvant treatment. Now, this patient is different. This is immature teratoma with a malignant transformation. This 9-year-old boy with headaches and ETB and the biopsy was done. This is a tumor in a pineal location. And after the ETB and biopsy, the patient in 2 weeks, there's a rapid growth in 2 weeks. So this tumor was resected and larger tumor samples obtained. That showed immature teratoma with cartilage, mesenchymal tissue, and primitive neural elements. Now, about 6 months later, or maybe actually 3 months later, the patient showed some evidence of the disease. And this was biopsy, and it turned out to be a mature neuroepithelial tumor. But about 8 months later, the scan showed concerning abnormalities. And after the resection of the twist mass, it turned out to be a PNET. And the patient needed subsequent oncological treatment with craniospinal irradiation together with chemotherapy. But this patient is still alive. This embryonic carcinoma is quite interesting. This is found usually together with within the mixed germ cell tumors. They is probably the most aggressive component of the mixed germ cell tumor. This is very interesting because that replicates the structure of the early embryo, so-called inner cell mass of the breast cyst or gastrula, like this, and forming so-called embroid bodies consisting of germ discs, and also some attempt of the formation of the amniotic cavity like this. So this is an extremely primitive the tumor. Now, yolk sac tumor, so-called endodermal sinus tumor, is representing the yolk sac endoderm. And histologically, there's a lot of myxoid matrix resembling the embryonic mesoblast. But the interesting part is Schiller-Duval body, which is the essentially tumor is forming perivascular rosette-like appearance. And surrounding is an attempt of the formation of the yolk sac, and that is compressing outer layer, which is also flattened the tumor cells. And this is AFP stain is positive, and this is one of the hallmark of yolk sac tumor. Now, choreocarcinoma, this is extra-embryonic differentiation along the trophoblastic lines. They are cytotrophoblast and syncytial trophoblast giant cells. And on this image, you can see it's a pale tumor cell that is a cytotrophoblast, and darker one is a syncytial trophoblast. And this is surrounding the cytotrophoblast area. That is a reminiscence of the arrangement of the placenta. And also another important character of choreocarcinoma is their vascularity. There's a very ectatic vascular channels and blood lake, and also evidence of the hemorrhage. And it's a histochemical study stain showed the HCG staining in the cytoplasm. So this is one of the examples of hemorrhagic choreocarcinoma. It's a very rapid growing. This is only 10 days apart, CAT scans. This is a very old scan of mine. This is choreocarcinoma. Now, how are the mixed germ cell tumors? And this is a combination of variety of cells and also expression of the tumor markers. For instance, this patient had a disseminated germ cell tumor with elevated beta HCG. We did not do any biopsy. This patient had a very high HCG. Therefore, the patient was treated with ifosfamide BP16, and the tumor was completely melted away. So we don't have any histological confirmation what this tumor looked like. How about another one here? This is a 19-year-old boy with double vision, and there's a very high elevation of the tumor markers. And the endoscopic biopsy showed a mixed germ cell tumors with yolk sac and choreo component, and AFP and HCG keep climbing up before the treatment. And then the patient received the chemotherapy, and then this tumor is totally resolved. And this patient had a small residual here like this. So this residual underwent the so-called second look surgery, and benign epithelial tumor component was noted, but there's no yolk sac or choreo component. And all those tumor markers normalized after the induction of the chemotherapy. Now, for statistical purpose, age is very common, somewhere around late teens, around mid-teens is probably the peak in the pediatric population. But another peak happens in a very early stage of life. Now, male to female ratio is 4:1, and according to the statistics, this is more common among the Far Eastern, like Japanese and Korea, probably 5 times more than the USA or European counterpart. But this is interesting. Caucasian group, gonadal germ cell tumor is much more common than Japanese group, almost 6 times more. Now, the location of germ cell tumors happen, or pineal location, supracellular or basal ganglia. Intracranial germ cell component, this is the most common site. But in the young, like infant to sometimes newborn, they may present with holohemispheric tumor like this, or posterior fossa, or else sacrococcygeal tumor. This is probably not the neurosurgical disease unless the tumor extends into the spinal canal, which is relatively uncommon. Now, based on our statistics, the solitary, so-called among the 84 intracranial germ cell tumors, the solitary pineal location was 50%, which means the rest of them is somewhere else. Solitary supracellular location was 26%, about 1/4, and 20% is a bifocal, which affect the pineal and supracellular location, and the basal ganglia is much less common. Now, when you look at germ cell tumors in the central nervous system, pure germinoma is about 2/3, and non-germinatus one is 1/3 of the cases. And the germinoma tend to occur in the supracellular, basal ganglia, or the older patient group. On the other hand, non-germinatus germ cell tumors usually happen in the pineal and the younger children. This is my own data of the past 20 years. The germinoma, this is pineal germ cell tumors. Pineal location, germinoma is about 55%, and the so-called teratoma is a part of the mixed germ cell tumor or pure teratomas, about 1/3, 32%. And the rest of them are minor pure choreocarcinoma, embryonic carcinoma, and yolk sac tumors. On the other hand, supracellular germ cell tumors is a germinoma, or including suspected ones, much more common, almost 80% of supracellular germ cell tumors are germinomas indeed, and much lesser degree, about 20%, are so-called mixed malignant tumor, germ cell tumor, or non-germinomatous germ cell tumors. Variety of symptoms, but naturally they are related to the location of the tumor. Pineal tumor tend to present with hydrocephalus. The supracellular one is almost always present with diabetes insipidus. Sometimes we call occult supracellular germinoma, together with other hormonal or visual symptoms. The bifocal one is a combination of those two. Basal ganglion thalamic the germ cell tumors tend to present with progressive hemiparesis or behavioral changes. And the precocious puberty is relatively uncommon, but usually related to some increased the production of the HCG. For instance, this young boy, 4-year-old, calcification in the center, which is supposed not to be there, presented with 5 days headaches. So I did ETB, but nothing extraordinary. And that was March of 2011. And following the ETB and Omaha reservoirs, the patient very rapidly developed precocious puberty. And MRI showed increasing mass, like a cystic mass together with solid component. And at that time, the patient showed CSF beta AC 70 and serum 182, negative AFP. But serum cholesterol is quite high. And testosterone level is quite high. Now, this patient received the chemotherapy, and then beta AC dropped down, but still persistent disease. So I did the craniotomy, and I resected this teratoma, and it's found to be a pure teratoma without the malignant features. And this patient subsequently received some radiation therapy and has been well almost 9 years now. Now, those patients present with hydrocephalus and particularly in the pineal location. But diagnosis-wise, when we do a history and the physical, the patient, the age and sex are very important. I have never seen the female pure pineal germ cell tumors except for one. And this is quite unusual to see the germinoma in the pineal location. Of course, we obtain the advanced neuroimaging and tumor markers. If the CSF is available, make sure we get tumor markers and the CSF cytology, and ultimate diagnosis probably require the surgical biopsy. Now, I do not get into the differential diagnosis. Pretty much everybody knows about it. So once we identify, we obtain the neuroimaging, usually obtain the CAT scans. I always obtain CAT scans to see calcification or hemorrhage in addition to MRI. But MR should include the spine MR as well. Now, calcification, as the last patient, 4-year-old boy with calcification, it's normal after 6.5 years. So first 6 years of life, should not be a calcification in the pineal gland. So if you see that calcification in that group in the pineal gland, you have to suspect there's something going on, particularly the tumor. Now, the bifocal germ cell tumors, we see more and more these days because we pay attention to read, make sure there's nothing going on in the hypothalamic location or the pituitary stalk. So we have to be analyzed very carefully about this. Sometimes patients present with a disseminating appearance like this. Now, tumor markers, AFP and beta HCG we obtain essentially very routinely. And the alpha fetoprotein, its half-life is 5 days, and beta HCG is only 1 day for the half-life. So it's very important to know what the half-life look like. Once you treat it, you have to get the idea when that's supposed to become normalized. The AFP can be produced by yolk sac endosome, fetal hepatocyte, or embryonic or intestinal epithelium. So the younger age, so-called immature teratoma, can produce that AFP, even though there's no yolk sac component. Beta ACG is usually produced by syncytial trophoblast. Other placental alkaline phosphatase or soluble kit, they, of course, we don't have any commercially available kits yet, but if you do have some special lab, we can measure those placental alkaline phosphatase and the soluble C kit. So when you do those tumor markers, AFP and beta ACG, you have to send both serum and CSF, because AFP tends to be higher among the serum sample. On the other hand, beta ACG appears to be higher in a CSF sample. So we have to combine those two. Now, because of most of the patients present with hydrocephalus among the pineal tumors, usually we do biopsy at the time of ETV. And if you do have don't have any flexible scope, you have to change the trajectory, like this patient. Sorry, here you go. Now, I cannot understand why. So I cannot produce that video in here. But anyways, when we do the biopsy, and if we do have a flexible scope, you can do a ETB first, and then turn the angle, and then take the sample of the tissue out from the posterior south ventricle. But the caveat is we have to make sure that this tumor is not too vascular, which sometimes we don't know because we don't do the angiogram. This is the angiogram which was done about 30 years ago. We still did the angiogram at that time, and it's kind of scary to see this kind of vascularity of this mixed germ cell tumor. And even though there's no conventional, the case of germinoma, sometimes it can cause hemorrhage. This patient developed some hemorrhage at the recovery room, although at the time of biopsy, there's no hemorrhagic events, but this patient became very sick because of hemorrhage at that time. Now, hydrocephalus management, usually we try to avoid the shunt because creating a shunt dependency on the CSF seeding of peritoneal space. Since we use that chemotherapy these days, it's relatively unusual to see the CSF dissemination, but I have seen way before the chemotherapy became popularized. And also when the place that shunt, it's maybe very difficult to attain that brain relaxation. Now, the southern ventriculostomy become very popular, but what shall we do when the patient has a hydrocephalus with a bifocal disease? It's very difficult to do this ETV with a large mass setting in a tubular scenario. We found that this tumor, particularly germ cell tumors, tend to respond to the use of dexamethasone. For instance, this patient had a large tumor, hydrocephalus, and the patient at that time, it was popular to do the EBD, and then we did this one. After the use of 3 days of dexamethasone, the tumor become maybe half a size, and this patient end up don't need any shunt. So this is one of the ways we may temporalize hydrocephalus by the use of decadron, because germinoma tend to have multiple the T lymphocytes, and that respond to the use of steroid. Now, teratoma is quite resistant to chemo and radio treatment, and naturally those are the surgical candidate. Geminoma is extremely sensitive, and sometimes to the steroid as well. But the malignant germ cell tumors are often sensitive to chemo and radiation treatment. Now, treatment principles like this, based on that, teratoma needs a surgical resection. Geminoma is not surgical the disorder, except for the potential biopsy. And those patients are treated with chemotherapy and the radiation treatment. Malignant germ cell tumors, chemo up front, and then secondary surgery, and remove the potential teratoma component, and then start to consider the radiation treatment. Now, pineal germ cell tumors, surgical approaches are practiced multiple ways, as occipital transtentorial approach, infratentorial supracerebellar approach, trans-corrosive as a transcranium, interferencial, or subchoroidal approach, and so on. There's a lot of approaches. I think I prefer that as occipital transtentorial approach because of comfort. This is another common approach people use, infratentorial supracerebellar approach. And the exposure is probably about 4 centimeters sideways. And then surgeon's comfort. I think this is probably most important, because most of the time we have to bring the patient on a sitting position, and the hand becomes very tired. And also you cannot use the assistant because you're taking up all the surgical space with both hands. The vein of Garen is above the tumor, and blind spot is a supratentorial component. But some people claim that this is a midline tumor, so midline approach, like infratentorial supracerebellar approach, is the best. I do not dispute that claim, but the placing the patient on the sitting position, and also comfort, and also availability of the assistant hand, I prefer to use occipital transtentorial approach. For that, usually patient is placed on a prone position, hockey stick incision, and then the either right or left side approach to the tumor. Now, in posterior interhemispheric approach is more appropriate because there is no bridging veins on the back and nothing to transect neural structures like splenium and also blood vessel. Even though you do the surgery, you don't see the precentral vein because you are slightly off. So it's relatively unusual to cut the precentral vein. And the vein of Garen is directly, you can see it and you can protect it. Posterior trans-corrosive approach, this is Dandy's approach too. Some people use it. I have used only a couple of times of this, but it's very uncomfortable because essentially going through those cortical veins is really killing me. Now, how about trans-corrosive interferencial approach? Usually in a pediatric population, still cavum, septum pellucidum is still available like this patient. So you can go through it. In this particular case, there is no space between the vein of Garen and tectum. So this patient was approached from the more frontal interhemispheric trans-corrosive approach through the cavum. But most of the patient, pineal teratoma, need much major operations, and geminoma is extremely chemosensitive. Therefore, we use that once diagnosis is done based on the CSF, beta HCG, usually we do the ETB plus minus of biopsy. But if you do have a CSF sample, and there should not be the beta HCG in the CSF, even though it's weakly positive, I would treat the patient as a geminoma with chemotherapy. And most of the patients respond quite well. Now, how about this patient who had elevated AFP? And this is patient, we don't do biopsy, just give a chemotherapy. And this tumor become densely enhancing mass, become very subtle residual mass. And this was done after the ETV and Ommaya reservoir placement and chemotherapy. Serum AFP dropped from 60 to 1. And then this residual tumor was resected. And as we anticipate, this turned out to be a mature teratoma. On the other hand, some tumors don't respond to chemotherapy, like this 18-year-old, very bright Northwestern student came over here with double vision like this. And AFP is high, HCG is also elevated. So probably mixed germ cell tumor, but unfortunately, the patient did not respond. Therefore, the tumor was resected through occipital transtentorial approach. And I'm sorry, I don't produce that video in here, but it's turned out to be the yolk sac tumor embryonic carcinoma component, and but the majority of the tumor was a teratoma, and this tumor was resected in total. The choreocarcinoma, this is a 17-year-old boy with emesis and headaches for 10 days, and it's clearly showed hemorrhagic in nature, hyper intense. And probably best one is a GRE or SWI imaging. This clearly showed the hemorrhagic nature. Now, usually, you can conclude that this is pretty much the choreocarcinoma. Therefore, the patient was treated with chemotherapy and then reduced the size somewhat, and then after second look surgery. But this patient, unfortunately, recurred and creeping up beta ECG, and ultimately patient died. This is one of the rare ones we lost. Now, growing teratoma is a concept that you have to remember. The normalization of the previously elevated tumor markers, yet tumor continue to grow during or after the chemotherapy. Those are the essentially mature teratomas without any non-geminomatous component. For instance, this 11-year-old boy with headaches, large mass, this T2 weighted image, and AFP is 7, serum is high, and he was treated with chemotherapy. Serum level went down to 5 from 264, but tumor continued to grow, particularly cystic component. This turned out to be a mature teratoma. And after resection with this tumor, the patient did not have any recurrence after radiation treatment as well. Now, supracellular germ cell tumors, 80% are germinomas, and some are multifocal, often with pineal location. And this type of tumor can disseminate to the ventricle much more than the pineal tumors. And the cavernous sinus is involvement is noted, 5 out of 42. Now, diabetes is a very cardinal feature of the presenting symptoms. Almost always those patients has evidence of diabetes. And also the hydrocephalus is much less common if you compare with pineal tumors. And sometimes those patients has a history of the diabetes insipidus, probably 2 or 3 years. For instance, this kid had 1.5 years history of DI, and this prominent pituitary stroke was overlooked in December of 2005, but continued to have diabetes, and follow-up scan showed the clear evidence of the tumor growth. And then this tumor was responded quite well to the treatment of the chemo. Now, this patient had so-called cavernous sinus extension with a 6th nerve palsy, and the 3rd nerve palsy with a double vision. And this kind of case is simply we can do transsphenoidal and nasal biopsy. for the sake of the time, I just skip this case. Now, how about the supracellular yolk sac tumors? This 11-year-old girl is very high AFP in both serum and also CSF. Chemotherapy was used, and very small residual scarring-like appearance. And at second look surgery, pituitary stalk is intact. You can see small cystic formation. It's turned out to be only fibrous tissue. And this patient showed essential resolution of the mass after the chemotherapy. And subsequently, the patient received radiation therapy and almost 15 years. She's a school teacher now without any recurrences. This is a more recent patient. This is a very large subventricular cystic mass. This is treated with transventricular approach. And initially, I thought this must be a teratoma, but he did have the teratoma with germinoma and yolk sac component, but the majority were benign teratoma. But this patient required oncological treatment. Now, when you look at the bifocal germ cell tumors, most of the pineal and the bifocal tumors occur among the males. On the other hand, supracellular mass is more common among the female. And diabetes insipidus bifocal tumors, if singular, so-called singular supracellular germ cell tumors almost always present with DI, but about 3/4, 75% of bifocal tumors present with diabetes insipidus. Now, still we are not sure the mechanism of bifocality of germ cell tumors in both pineal and hypothalamic location. Maybe a concurrent occurrence. Still, it's very hard to understand this concept. How about CSF dissemination, or maybe subependymal direct extension? For instance, this 14-year-old boy with evidence of multiple mets, this is bifocal disease, the pineal location and supracellular location, but also there's forced ventricular evidence dissemination on the MRI. So this is treated with initial chemo in both regions melted away. So could be a CSF dissemination. When you look at this recent publication by Homeland, this is just looking at CSF flow through the subventricle. There is supracellular cistern, tuberosnerium location, or pineal location. The flow is diminished. So this area, particularly supracellular, the tuberosnerium location, impedibular location, maybe a kind of stagnant through CSF circulation. Maybe that's the reason why the second lesion may occur. But on the other hand, those patients, particularly germinoma, tend to have this very typical appearance of germinoma, kind of creeping along the wall of the subventricle. And at the time of the endoscopic procedure, you can see kind of thickened flow of the subventricle. So this could explain the so-called subependymoma extension. Now, how about basal ganglia germ cell tumors? This 11-year-old boy with 3 weeks history of hemiparesis, anorexia, and asthenia. And this is a kind of ill-defined appearance, but please note ipsilateral cerebral atrophy. And this has been well documented in the literature. Perhaps some axonal degeneration, which means must be a very chronic disease process taking place. But this patient had positive CSF cytology. As you can see, is that the lateral ventricle had some tumor, and this turned out to be a germinoma, and that was treated accordingly. For the sake of the time, I just skip this. Now, adjuvant therapy, of course, chemotherapy is very important, and now people use carbo, BP, and ifosfamide combination. The radiation therapy, initially, the patient received craniospinal axis radiation that changed the whole brain, and then diminished to the limited or so-called involved field radiation. And now, most of the people use the whole ventricle radiation treatment. Now, this was justified by two groups, the French group and also American ACNS group. Both showed involved field radiation therapy, it tend to fail, and the limited field or involved field radiation therapy failed. Therefore, a more recent COG study for the localized germ cell tumor treatment, for instance, this is the non-germinal germ cell tumor treatment scheme. Radiation is used for whole ventricular irradiation after 6 cycles of chemotherapy, alternating carbo BP and ifosfamide BP combinations. For the germinomas, this is the same thing, whole ventricular irradiation after 4 cycles of carbo and BP pre-radiation chemotherapy. But you have to remember, these are so-called localized CNS germ cell tumors. So I think they did a very good job. This is a recent publication based on this ACNS 1123. That means the whole brain radiation, 30 gray, and additional tumor boost to where the tumor was, like a pineal or supracellular, and attained quite good survival, almost 90% recurrence-free survival for 3 years. The similar publication was made from the PSYOP, and they also noted the focal radiation field are sufficient, but this is misleading. This should be a whole brain radiation, or correction, whole ventricle radiation treatment. So in conclusion, still we are not 100% sure what is histopathogenesis. There's a lot of research has been done, particularly using the epigenetic studies with molecular biology, and we know more in the next few years. And histology is so important, and particularly tumor markers dictate what kind of treatment we should provide. Surgical resection, teratoma and immature teratoma are certainly the surgical candidate, but the mixed germ cell tumors, usually we recommend the second look surgery to make sure there's no residual radio-resistant mass, such as teratomas. And also, we found that the great majority of germ cell tumors are oncological disease, and we need a lot of help from our pediatric neuro-oncology group. Well, thank you very much for your attention.
Thank you, Ted, for this nice and very illustrative and detailed presentation. Very interesting. And does anyone have questions? John, do we have any question?
Yes, I believe Uday. Go ahead, Uday. You can come on in and ask your question. Uday, go ahead. We're not hearing you, Uday. I guess the audio is not working. Can you type your question in, please, Uday? Because we're not hearing you. And back to you guys. I don't know if there are other questions or comments. I'll try to get Uday's question when he's typing it in now.
Okay. So I just want to ask you, Ted, in case of a mixed germ cell tumor, the mixed type, when you have start with the chemotherapy and you have normalized the tumor markers, Do you go again for a second look surgery, or you go directly for another session of chemotherapy first, if you still
No.
have them not normalized?
Usually,
if you have the markers still high.
Yeah, if indeed there's a protocol set for the so-called germinoma, this is 4 cycles, and non-germinomatous germ cell tumors, we use 6 cycles. And if indeed there's a persistent disease, either radiographic evidence or persistently elevated germ cell tumor markers, I would recommend to do a second look operation and take a look at it and what component of the mass is indeed present. So, but it's the most of the time, the tumor vascularity is also much diminished together with the size of the mass. So second look surgery provide much better safe net for the operating surgeons.
Yeah.
Okay, we have a question from who? We have a question from Uday. Well, Uday says, is there a change in the pattern of drug delivery in the form of nanotechnology? Is it improving outcomes? In other words, is nanotechnology improving the outcome of drug delivery?
Yeah, it's a Northwestern has a big nano center, and they are doing a lot of the new drug delivery method, but I'm not aware of new thing going on specific to germ cell tumors.
Okay, thank you.
Okay.
Yeah.
Good. Ted, so I see you still sharing your screen. If you could,
I'm sorry.
Yeah, I can get that off. I can stop it. Okay. I got it.
Oh, stop share. Okay, here you go.
Okay.
Sorry.
I got it. There you go.
Okay, thanks, Dad. That was just a fantastic overview, and clearly you've built up a huge series. I mean, these sorts of tumors tend to predispose in Asian groups. And did you see a lot of these in while you were in the States, or did you see a lot of them prior to moving across, or did you find that balance between the geographic movement even or not?
So you have seen most of your tumors in the States, or you have seen them outside? That's the question there. Yeah.
Are you asking me?
Yeah. I mean, yes. with Asian predilection for germ cell tumors.
You know what? Actually Asian population is where I practice medicine in Chicago. Not many so-called Far East Asians. Occasionally I see the Koreans, and but the majority of the patient I deal with is American people. So I did not see any so-called racial thing, except for moyamoya disease. Moyamoya kid, we see a lot of Korean or the Asian populations still, but I did not see any tendency of American Asian populations.
Okay. No, thanks, Ted. That's a very useful point. Okay, then to round off our trio of pediatric neurosurgery giants, I'm going to introduce our third speaker. So Martin Schumann is a full professor of neurosurgery in Tübingen at the Eberhard Karls University in Tübingen, and he's the chief of pediatric neurosurgery at the University Hospital in Tübingen. And Martin is a widely experienced and very well respected pediatric neurosurgeon on the European circuit and internationally as well. He serves on the ESPN, the EANS, and he's done tremendous work in multiple sort of areas of pediatric neurosurgery, mostly in the monitoring of intracranial pressure as it relates to certain types of hydrocephalus. He also chairs the neurofibromatosis clinic at the Tübingen Hospital. So he's got tremendous experience in that sphere as well. And in that context, he's going to give us the next talk, which really involves the treatment of optic pathway gliomas. So Martin, if you want to share your screen and get started.
Yes. So, so you should see my screen now.
Yes.
And we are trying to start it here. Okay.
Okay,
So,
perfect, perfect.
Perfect. So thank you very much, Llewellyn and Mohammed, for the invitation to talk on optic pathway gliomas, which is a very specific topic, again, for pediatric neurosurgeons, not only in NF, but also in the non-NF cases. I hope I can share some ideas on this also quite controversial topic. Where is this role of surgery in optic pathway gliomas? So why is it not? Okay, so some general considerations. We of course are always treating in a team in pediatric neuro-oncology. We are a large pediatric oncology center here in Tübingen and a reference center for pediatric oncology and neuro-oncology. And so surgery is just one of 5 pillars in pediatric neuro-oncology. And I think optic pathway gliomas very nicely demonstrate that this is a team play and that you cannot solve these problems alone. We all read, I think, as medical students, Samuel Sham's House of God, and we were probably, I was laughing at rule number 13, the delivery of good medical care is to do as much nothing as possible. And in the context of House of God, that sounds quite funny, but the longer you're in pediatric neuro-oncology, you realize that this is probably the best essence of the whole book, that we really need to do as much nothing as possible in most of our tumor cases. But if we act, we have to act very decisive and as clear and radical as possible or as necessary. But in these eloquent area tumors, it is a little bit like climbing that Bianco crest here of Pittsburnina. On the shadow side, you have the loss of function. On the sunny side, you have the incomplete resection. And ideally, the goal of neurosurgery is to walk right in the middle on the crest, so achieving a total resection without losing any loss of function. Optic pathway glioma and optic hypothalamic glioma teach us, however, very impressively that in these type of tumors, you really need to walk on the sunny side. There is no way of losing function or visual function or hypothalamic function, because then you really decrease the quality of life of those patients tremendously. So our surgery needs to walk on the side of incomplete resection in the majority of cases if there's a surgical indication. And that's part of the talk. I want to show you that neurosurgery in these tumors needs to be well thought and well tailored. Because we are treating low-grade gliomas, which have a slow growth and which have a very high overall survival rate, the progression-free survival is much lower because there are always some changes in radiologies. Tumor might change, contrast enhancement, they might grow a little bit and then stop again. They might. So it is a kind of benign disease, which is, on the other hand, very mean, but children in generally don't die fast of optic pathway gliomas. So when we saw this 17.5-year-old boy for the first time in 2016, we saw this optico-hypothalamic glioma, but going back, we discovered that this was already known in the year 2000 when he was 1.5 years. And you see, there's not so much change. There is change over these 16 years, but the tumor was here already. It was here in the pituitary stalk already. It grown bigger, but over all these years, he only developed hypogonatrope hypogonadism. and all other axes of the hypothalamus are okay. He has no diabetes insipidus. He has full vision. So what do you do with a case like this, which already shows you that it's kind of benign? So since we didn't know the dynamics between here and here, because there was no imaging in between, we did a biopsy, translaminar terminalis biopsy for molecular characterization. There was nothing special, no BRAF-KIA fusion or something like this. So we continue to observe, and until now in 2020, as on the last time, there's still no change. So we are treating kind of benign tumors in a very difficult location, which can be very mean on the other hand. So in optic pathway gliomas, it is like in real estate: location, location, location. These are the three things that count most, because you really have to analyze anatomy. Is this a pre-chiasmatic tumor only, so a truly optic nerve glioma? Do we have a mostly chiasmatic tumor, chiasma glioma? Do we have a total optic pathway glioma, also involving the optic tracts, and not only chiasm and optic nerves? Or do we have the full picture of the optic hypothalamic glioma, which contains the most vulnerable area of the hypothalamus, which you absolutely have to protect in its function? So first of all, you need to carefully study the anatomy of the tumor. The next most important thing you need to know is the Nf1 status. Do we have Nf1 case? We see a much higher rate of indolent cases which are not that aggressive. In non-NF children, especially, we have more progressive cases. So NF are the more benign optic gliomas than in the non-NF cases. So we check for Nf1 stigmata. The first thing you need to do if you have an optic glioma baby or child, to find out to which group is going to belong. And then the third most important thing is age. It is known that the younger children below 4 years or even below 1 or 2 years have the most aggressive course, and the older children have the more benign course. And you see these groups clearly differentiate in progression-free survival according to age. So there are three things: location, Nf1 status, and age, which determine a lot of your therapy, of your strategy, and of your general approach to the patient. The radiological tumor characteristics, you have to know that we have several components, and we can have several components, and you have to look out of them. We have the solid enhancing, we have the solid non-enhancing parts. So these are mostly pilocytic astrocytomas, so they can do everything with contrast. And we have the cystic tumors. Looking then at the T2 signal, we have those strongly hyper-enhanced at surgery, rather soft, fast-growing, often non-infiltrating, but pushing tumor components, which contain a lot of water. We have the normal, mildly hyper-intense, which generally tend to be harder at surgery, are slower growing. They can be infiltrating in the border or genuinely infiltrating functional tissue, for example, in the brainstem area. Then we have the non-enhancing, which are most of the time rather the slower growing, harder infiltrating tumor parts. And then there are the cystic components, which again can be fast growing or slow growing, generally don't infiltrate, and they don't respond well to chemotherapy or radiation. So from that characteristic, there are surgical components or classical surgical components for surgical therapy. These are these strongly hyper-intense, non-infiltrating, soft, pushing parts of the tumor, and the cystic parts of the tumor. That are the classical ones which you can address surgically much better than the infiltrating, harder, slower growing parts, because they are in the more functional areas. There has been this now meantime famous consensus conference in 2011 in Paris, published 2013, where they defined for several types of glioma in children, surgical indications. And for the OPGs and OHGs, it was agreed that we would mainly go for non-functional exophytic or cystic tumor paths with mass effects, that these would be typical surgical goals to reduce mass effect on functional structures, to remove fast-growing parts, to, for example, delay chemotherapy or radiation, gain time, or reduce tumor volume, which then is going to be treated with chemotherapy or radiation. So you debulk the tumor to leave a smaller volume for chemo or radiation. And depending on the location of the tumor, you choose different approaches. Anterior to the chiasm is the classic approach by subfrontal or frontolateral approach, midline or midline lateral. If the tumor extends lateral to the chiasm, we have the terional or temporal approaches, subtemporal, transsylvian, transtemporal approaches. And if the tumor extends into the third ventricle upwards or into the basal ganglia, it's a classical trans-colossal, sometimes transfrontal, transventricular resection. And for the cystic components, it's an excellent opportunity to use endoscopic cystic fenestration transventricular to decompress these typical pilocytic tumor cysts. Speaking about neurofibromatosis, we all know this is a rare disease, but it's one of the more common rare diseases located on chromosome 17. And the gene product, the neurofibromin, is a negative regulator of the oncogene RAS. So we have a RAS-MAP kinase pathway disorder, which is completely penetrant, but extremely variable in the phenotypes, even within the family. So children normally do not have the same phenotype than their parents. Only 50% of these children develop an OPG, and mostly they do so within the first years of life. If you haven't arrived with an OPG by age of 10, there are very minimal chances to get one later. And that is a very important information. Many NF patients are screened forever if they would develop an optic pathway glioma. After 10 years of age, you can basically stop. It's not going to happen anymore. So a big question, if only 15% of the children will get an OPG, is who will get it? And we tried to answer that question when we had all these whole genome sequencing methods, and we tried to do this with our colleagues from Heidelberg and Hamburg, and looked in 77 patients and found nothing. So basically there is no association to the position or the type of mutation and the likelihood and chance to develop an optic pathway glioma, because that would have been very nice if a little gene test in the patient on the level of the mutation would tell you if this is a risk candidate to develop an optic glioma, but unfortunately it isn't. So the question is now, do we have to perform annual MRIs in NF1 kids in the first 10 years of life? And I see quite a number of centers and children which get every year sedation to have an MRI in the first 6 or 7 years. And the French addressed in this very nice study that question. And they looked at 306 first MRI screenings, and only 45 of these children had an optic pathway glioma. So these are corresponding to the 15%. The mean age at discovery was 3.5 years. I told you it's below 10, mostly below 6 years. Only 13 of those patients were 13% were older than 6 years. Most of them are asymptomatic again. So if you have an optic pathway glioma, your likelihood that it is asymptomatic and not going to bother you is much higher than it is going to be symptomatic. And the progression of those asymptomatic, about 30% progressed, the symptomatic, about 44% progressed. So only 9 of those 45 tumors became symptomatic, and mostly it's visual symptoms. 6 with visual symptoms had treatment, 6 of 45. This is 13% of all OPGs, and only 1.7% of all NF1 cases. So you need to be aware if you do an MRI scan in an NF1 kid, your chance is not even 2% that you discover a tumor that later on will need a treatment. So do we have to perform annual MRI in NF1 kids? Certainly the answer is no, because even the pure existence of a discovered OPG is no treatment indication. And I have seen children that have received 1.5 years of chemotherapy just for the pure existence of an optic nerve glioma. So there's no sense in doing these MRIs. And a volume progression of an OPG without any visual deterioration, again, is no treatment indication. You would not treat an optic nerve glioma just because it's growing a little bit if the vision remains perfectly or unchanged. And a change in contrast uptake, again, is without any meaning in these tumors. So what we need to do in these children is to perform biannual vision tests in NF1 kids. And the smaller the kids, on the other hand, and that's the main thing, the bigger is the challenge. The smaller kids are those which will have a tumor, which will have maybe become symptomatic, and they are more difficult to investigate. So if possible, we try to get these kids for once a year in a specialized ophthalmology clinic for children in our own center or in other centers where they really are very experienced and trained in assessing these small children. And only if we have the impression that there is any visual problem, we will do an MRI scan in children with NF1. Because they are very much stable. So here we see one bilateral optic nerve glioma stable over 5 years in this patient, no change at all. They are mostly diffuse within the optic pathway in NF1. They are very rarely exophytic, and they very rarely extend within the third ventricle. So these are no surgical tumors. They have a more indolent course, often stable, and the visual function is the most important thing. You can see the overall survival is excellent in this NF1 cohort, but the event-free survival is much lower because there's always some change of contrast enhancement, and that is already counted as a progression in this kind of analysis. Is the change in vision and the tumor volume correlated? So does growth mean that the vision is going to deteriorate? No, clear answer. We have seen everything. We have seen increase with change without increase of the tumor without change of vision or hypothalamic function. That is the most common scenario. You see some change in volume, but nothing happens. We have seen an increase concomitant with change in vision, but you can also see visual deterioration without any radiological change. And we have seen spontaneous regression in these children. So no correlation at all. You need to follow the function, the visual function. Now, which treatment options do we have in NF1 children? There's no place for radiotherapy in NF1, period. Because why don't we want to irradiate in NF1 patients? Because it is a tumor suppressing disease. A tumor suppressor is missing. So we have a high rate of malignant transformation, much higher rate after radiation for secondary tumors, for malignant transformation of pilocytic astrocytomas, or for other late vascular effects like Moya-Moya type of development in after radiation. The standard treatment protocol is carboplatin and vincristine, and you see you have a third progress under therapy, 40% are stable, 30% improve in this study from Fisher from the United States, from Pittsburgh, and this European meta-analysis showed pretty similar results. So a third progresses, a third to 40% progresses despite chemotherapy. The other ones you can treat. There's an alternative which is less toxic and has less side effects. Is vinblastine monotherapy, which can have similar effects. And very much upcoming in the recent year are the MEK inhibitors, because they address the pathway that is genetically altered in NF1 like selumetinib or trametinib. The problem with the MEK inhibitors is they're just about to be licensed. So selumetinib has just been licensed in the USA for Nf1. They're extremely expensive, and healthcare insurance don't cover for them in many countries. And when you stop them, the tumor just continues to grow in many cases. So they shrink the tumor volume, but they don't kill it. And if you stop the inhibition, tumor might progress in a number of, or in a considerable number of cases. So you're not solving the problem forever, and we will have to learn a lot when to use MEK inhibitors in the best way. So what is the role for surgery in optic pathway gliomas or optic hypothalamic gliomas in Nf1 patients? So basically, we contribute to disease control in the very well selected cases. I will show you some examples of blindness. If there's blindness in one eye, it's an excellent surgical indication to do something if you need to do something. There's a biopsy for molecular analysis. It's an increasing indication that we need the molecular profile, the genetic profile, the mutation profile of these pilocytic astrocytomas to address them with specific targeted tumors if they are resistant to standard chemotherapy. And we want to reduce non-functional masses before when chemotherapy fails. So if you have a prechiasmatic tumor where the blindness has already occurred and the tumor is growing and compressing the chiasm, and you're afraid maybe it goes to the other side, which not often happens, but it's more the compression on the chiasm, this is a very good surgical indication. So this child in the early ages was even radiated for the prechiasmatic tumor. She was blind on the left side, and now recently the tumor grows, and you have the deterioration of vision on the right side, and this is an excellent case. You see the big right tumor in the front, and you cut here the optic nerve where it leaves the optic canal. You remove the tumor, you stop in the chiasm, and you have a very nice surgical resection. The vision improved in this girl because you take off the compression of the chiasm. You can preserve the crossing fibers if you stop early enough, and preserve a full visual field on the remaining eye. If you have a predominantly intraorbital tumor, which presents with exophthalmos and pain, oncologists tend to treat that just out of reflex with chemotherapy, but it doesn't solve the problem. It doesn't take away the pain. It doesn't take away the exophthalmos because these tumors don't shrink under chemotherapy. And again, that's an excellent surgical indication. So we have this 3-year-old boy with exophthalmos on the right. When this was diagnosed in July, his pupils were still reacting. In December, they weren't reacting anymore. So very, very fast growth. In 5 months, this tumor has doubled in size. The boy became blind, and then he was scheduled to go for chemotherapy. And we came to us as a second opinion, and we decided to resect the tumor from the bulb to the chiasm. I'll show you later a video in a different case. This is 1 month post-op. This is not tumor, what you see here in the orbit. This is the dura, because the tumor is around the dura, and to protect the orbital content, you do a purely intradural resection. And if you have an extended dura, like in this case, you have dura in here. And we see the chiasmatic border, and this is 3 years post-operative. So the dura has shrunk. We have no recurrent tumor. The chiasm is totally clean, and we have saved this boy from 1.5 years of chemotherapy, and he has a normal eye movement. He has no pain, no exophthalmos. So a very good surgical indication in a well-selected case. Another indication is the growing masses in non-functional regions which are resistant to chemotherapy. And this is a typical story, 11-year-old girl which had vincristine carboplatin in 2012 to 14, another cycle in 2017 to 18. Then she had a MEK inhibitor, severe adverse events, and she had to be stopped. Then she was for a year on bevacizumab. the tumor was progressing, and she had several biopsies and 2 partial resections and further progression. And now she was planned for large volume radiation in spring of this year, just a few weeks ago. And we were asked for a second opinion. And you see, between October 20 and March 21, the tumor progressed quite rapidly, but there's no progression in the chiasm. There is little progression in the hypothalamus, but the majority of the progression is in the basal ganglia and this large cystic component, which is also nicely seen here on the coronal slides. So we have a cystic component, we have a large volume component, which is hyper intense, and that is causing her problems at the moment. So we decided for a trans-colossal resection. And you see, we took all the rapidly progressing parts. We did not take the hypothalamic part. We could have taken, to be self-critical, a little bit more out of that, not down here, but a little bit more posterior here in the hypothalamus. I think it was correct to stop here. Posteriorly in the cerebral peduncle, we could have taken a little bit more. So she was just discharged today. She's fine, she has nothing. Her vision improved a little bit again because the compression from the top has disappeared. And that is a good opportunity to help in disease control. But we haven't cured the disease on the other hand. So we still need to see how we proceed with the other tumors in this girl. And maybe she needs some more surgery. Now we switch to non-NF cases. We already learned that in non-NF optical hypothalamic glioma, the progression rate is much higher. And the French national study showed that the absence of NF1 and the age younger than 1 year, these are the 2 main risk factors for a malignant course in these tumors. The same thing shown in Ireland. The NF cases had 60% progression. The non-NF cases had 60% progression versus 24% of progression in NF1 cases. And especially the small children younger than 1 or 2 years is a very bad prognostic factor. These tumors will progress, and you don't have to wait in such young children for treatment. You can start right away with chemotherapy. This is a child, for example, with Diencephalic Syndrome, something very typical for smaller children with these hypothalamic tumors. So you see multiple progressions or multiple seeding of the tumor already all over in the basal cisterns and the 4th ventricle, and the large diencephalic tumor, which needs to be treated by chemotherapy. This is not an upfront surgical tumor if the child is in a Diencephalic syndrome. Most of them are pilocytic astrocytomas and these pilomyxoid type of tumors, which need more molecular characterization and have been known as a separate entity since 2007 in the WHO classification. They are clearly more aggressive. So you see the age of diagnosis is younger, the mean progression-free survival is significantly shorter, the mean overall survival is significantly shorter, and the local recurrence rate, even after kind of radical resection, is quite high. So this is a subtype which behaves very differently. In 2015, it has the first molecular genetics showed overexpression of several types, deletion of CDKN2A, loss of ATRX expression, or TERT-P mutation are typical features for these PMA-like aggressive pilocytic astrocytomas. So they need special attention, the dangerous ones. So younger children, more aggressive, less responsive, something you need to remember if you see this in non-NF cases in younger children. In general, still, the long-term outcome of these low-grade non-NF1 associated tumors is still good. So this is a study from Andy Anderson Cancer Center in Houston, and you see excellent overall survival. of course, the progression-free survival. So there are radiological changes, but these children don't die. Again, the age difference and a clear molecular influence. So those with a BRAF-KIA 1549 fusion have a much more aggressive course and tend to need treatment. But we also have, for these tumors, we can use targeted therapy in addition to standard chemotherapy. But looking now at the different types of treatment, chemotherapy is the worst option. Radiation therapy is much better. If it would not be for the significant negative long-term effects after radiation therapy, this has become very clear. And the age for radiation, which was in the European recommendations 8 years in the previous study, has now shifted to, if possibly, 16 years or later in the new PSYOP logic protocol, because it has come up that there are problems and all these patients survive. They survive and they will feel their long-term radiation effects. But the diagram also shows that surgery, if it is indicated, is the most effective treatment, also in optical hypothalamic glioma, if you can use it to the benefit of the patient. So I'll show you again, non-NF cases. We have now acquired about 6 or 7 of those pre-chiasmatic intraorbital tumors, which we resect through a transfrontal transorbital approach. I'll show you a video on that because this is a nice pediatric skull-based surgery, which is really helpful for the patient. So we do a frontolateral craniotomy, and then we do an orbital roof craniotomy with a mini drill. So you take out the orbital roof. Then here's the superior orbital fissure, and then you drill the optic canal in these patients until it is totally open. You have to be careful to the median so you don't enter in the ethmoid cells. Then you take out part of the clinoid, like in adult skull base approaches. And after having here, you don't need to do a total clinoidectomy, anterior clinoidectomy, but you totally expose the optic nerve. Then you open the periorbital in a T-shaped fashion, which is important for later reconstruction because you have to reconstruct the periorbit. You have to preserve the branches of the trigeminal nerve, the frontal nerve, and the crossing oculomotor branches. And then you go in between the muscles, you dissect alongside the muscles and go straight down to the dura. And the dura of the optic nerve shaft. And inside, then you do an intradural resection of the tumor, and you maintain all the contents of the orbit outside. So within the dura, you're safe. Nothing can happen. You cannot damage anything if you stay inside the dura. So you can do debulking with the CUSA. Tumors tend to be pretty hard, so often you need to use the scissors. And then you cut as close as possible to the bulb, but you must not injure the bulb because you will have problems with an injured eye bulb. So you need to go close. This is one of the critical points. And then you enter the orbit canal until you see the CSF coming. You leave that part of the tumor inside the optic canal, and then you do a regular standard intradural subfrontal approach. You see the optic nerve where the tumor ends. You transect the optic nerve, which is quite painful for a neurosurgeon, which is trained to preserve visual function. And then is a little bit delicate, the dissection around the corner, because you don't want to open the dura there, because you need to get a watertight closure later on. So you do an intra-extral dural resection until you have taken it out and preserve the ophthalmic artery. If you open the ophthalmic artery, it's like doing a hole in the carotid artery. There's no difference. Then you seal with a piece of muscle the optic canal from the inside, and then we seal it from the outside and reconstruct the orbit. And in the end, you can fix this. In the meantime, in the video, you will see I'm still using a plate. In the meantime, I'm using just PDS sutures, which works equally good, and you don't leave anything behind. After a period of swelling, you will have a very nice movement of the eyes, no anaphthamos normally, and from the outside, you see no difference to the preoperative status. So a good indication in selected cases. There's also another indication, like I showed you before in the NF, the same exists in non-NF cases, a 3-year-old identical twin with this large tumor. So on the first glance, you think, okay, this is an unresectable tumor. But in the second glance, you actually see that the optic nerve on the contralateral side is below this cyst. This is the optic nerve. This is the optic nerve. It is not involved in the tumor, and she was almost blind on the left eye and right eye, and she had a very good vision on the left side. So approaching this tumor here, we see the tumor mass, we see the carotid artery, and after reducing the mass, we have the left optic nerve, we have the right tumorous nerve, and you can then cut at the skull base, at the optic canal, the tumor, and you take it out from the chiasm, but you don't need to dig in here because you don't want to injure the crossing fibers. It turned out to be a rare case of a ganglioglioma of the optic chiasm, so it must not always be, or it has not always be a pilocytic astrocytoma with a BRAF V600E mutation. And we have a nice surgical result. And tumor residual, of course, inside the chiasm. And this was the immediate postoperative scan. We had also had some tumor residuals in the front here, which we actually inadvertently left. We didn't see that there was still something left. And this was in 2014. I still couldn't tell apart until now. I don't know which is the patient's because they are really identical. I always have to ask the mother, and you can't see from the outside. When she was 5 years old or 6 years old, we finally could confirm that she has a full visual field on her left eye, and the tumor is stable ever since. This was the last time when she came here 8 years after surgery with no tumor progression. So surgery can cure optic gliomas if it is the right case, and if surgery induces a senescence of the tumor and the tumor stops growth. Exophytic tumors with large mass effect 11 is also a good primary surgical indication. So this boy came with a very low vision on the right eye, a good vision on the left eye, hydrocephalus, polycystic tumor, very good case for a trans-colossal resection. So we reduce the tumor and you leave everything that is problematic. You leave in the optic tract, you leave around the hypothalamus. So here's the hypothalamus on the right side. So you just stop there. There's no reason to go. And this is now, he was just here this Monday by chance, and this is now 3 years post-op, and the tumor has not changed in the last 3 years. So if you're lucky, surgery, like in other locations of pilocytic astrocytomas, induces a senescence of the tumor residual. They don't grow, they stop. If you're lucky. If you're not lucky, you have gained time for the patient. Some of these tumors you might need to treat surgical when they are relapsing as soon as you stop chemotherapy. So this boy with a 5-year diencephalic syndrome, impaired vision, got chemotherapy after endoscopic biopsy and a shunt. Then this was the end of chemotherapy, and mother was so stressed and traumatized by chemotherapy that she didn't show up for 2 years. She just was lost for follow-up because she swore she will never give her child chemotherapy again because it was so terrible for her and the family. So in 2018, she comes with visual decline, and he was not seeing that much anymore. And now the tumor has grown in the last 2 years. We did a trans-colossal resection, vision improved, no hormonal deficit, no nothing. And then mother promised to come now for follow-up. She didn't do. She didn't show up for a year. And a year later, the same story. No visual deterioration. Tumor has rapidly recurred within 1 year. So in some tumors, you do not induce anything by surgery. Surgery cannot cure the disease. So I told her, I'm not going to operate on your child again if she does not agree to any chemotherapy afterwards. And we talked to the boy, and he said he wants surgery and he wants chemotherapy. So we, again, a year later, did a trans-colossal resection, reduction of the tumor. And this is now after 1 year of on and off vinblastine treatment. So we still have some compliance problems of the family, but it was enough to control the tumor basically in his status. And we will have to see how the story continues when we stop vinblastine in a couple of, maybe in another year's time. So in summary, surgery in optic pathway gliomas and optic hypothalamic gliomas is a team effort, and we just are one medication which you can use for disease control in a benign tumor disease, which has a very good overall survival. The surgical options exist in both NF and non-NF cases, but it's always well selected, and many cases will not need a surgeon, but other surgical treatments or just observation. In pre-chiasmatic cases with unilateral blindness, always consider surgery because you have nothing to lose and only to gain. The main goal in the most occasions is tumor volume reduction and removal of the mass effects before or after chemotherapy and radiation, to gain time or to, if you're lucky, induce senescence in these tumors and achieve cure. Thank you very much for your attention.
Thank you very much, Martin. That was a very comprehensive overview. Thanks so much. You clearly have a lot of experience with that. Do you find a lot of them come to you because of the NF clinic? I mean, from your numbers, that seems to be a reason why.
Partly, at least from the NF1 cohort, we get referrals from all over Germany, and but not explicitly for the non-NF cases.
Okay.
They are not coming because of the center.
Okay. Great. So look, we're running a bit over time, so I don't see any obvious questions pending still, John. I'm not missing any, am I?
No, I don't see any questions either.
Okay. All right. Mohammed, then maybe I'm just going to leave it to you to wrap up then. I think we're already half an hour over time.
Yeah, I just have one question to Martin. When you're doing this through the frontal approach and you're removing the orbital roof, do you need an ophthalmologist with you, like to identify the muscles? Sometimes the tumor is pushing the muscles upward and the fat, the periorbital fat, when you open the periorbital. You have some with you, or?
Yeah, we have a good collaboration with our periorbital surgery team. We have a pediatric team which also does the periorbital surgery. So all the first cases I did together with my colleague. And I think it is especially helpful and reassuring to decide where to cut behind the bulb, because the ophthalmologists really feel injury to the bulb, because this can induce a dystrophic process on the contralateral eye. This is this sympathogenic, I don't know the explicitly the word, but if you injure the bulb, you can get an immune reaction to proteins or certain antigens, which then can affect the other side. So they really fear that. And in the beginning, I found it very helpful to have the ophthalmologist also with the dissection within the orbit. In the meantime, the last two cases I have done without them. But I can recommend, if you have the ophthalmologist there and their experience, you would be stupid not to use it.
Mm-hmm. And have you ever used the mesh in the reconstruction? of the
No,
roof?
never use the mesh. I always use the bone, and in the meantime, I don't do this plate. I only did this in the first 2 cases. Now I'm just using normal sutures. The alternative approach is that you only do a supraorbital craniotomy,
Orbital, yes.
take out the orbital rim, and pull the eye outwards, so you can nicely take out the tumor parts inside the orbit, but you cannot remove the part in the optic canal. And then you transect, take out the intradural part, you take out the intraorbital part, but you leave the tumor in the optic canal. I have no personal experience with that approach, but I know some colleagues are using that approach. I'd rather prefer to remove everything.
Yeah, great. Thank you. Very interesting presentation. And does anyone have any questions before we can wrap
Yeah,
up?
I have. Martin,
Yes,
thank you
please
very
start.
much. That's a great presentation. I have a question that you go through a intracranial epidural approach and without removing the orbital ridge for the optic nerve tumor resection. And I had always some difficulty and concern to preserve superior rectus and also the branches of the south nerve. Do you have any trick for that?
I was just kicked out of my connection and I had to reconnect. Ted, can you repeat your question? I just
so when you go the subfrontal approach and then naturally you go from the roof of the orbit to resect that optic nerve glioma. My concern is the going through the superior rectus. Obviously, you have to separate away, and also those branches of the oculomotor nerve, which supply. How do you have any trick to preserve them?
Yeah, you just go stepwise. So the first branch you see is the frontal branch of the trigeminal nerve. So you push this aside, and then I take 2 little retractors to open the channel, and then you have the crossing branches of the oculomotor nerve to the superior rectus and to the median rectus, and you have to do this in little windows. So you do the first resection before the crossing oculomotor nerve fibers and take the anterior part to the globe. And then after you have gained some space, you go to the next window. And then you have, in the end, you have where the muscles insert close in the conus region. You again have to work over a little bridge. And through these 2 or 3 windows, you can take everything out. And we haven't had any permanent damage to oculomotor function so far.
That's terrific. But those nerves those branches are very small, right? I think it's those 3 years old kid.
Yeah, but it's okay. I mean, we treat many very small structures, and I'm sure you, as a so experienced microneurosurgeon, you will think they are big.
Thank you.
I think it also depends on the size of the tumor. That sometimes the optic nerve tumor is very big and pushing all the nerves and the fat. So sometimes it's very stretched and difficult. I had some problems with that. I had a third more nerve injury with the ptosis after the surgery and superior rectus injury, where I opened the periorbiter, and there was an ophthalmologist. We could never identify it because the tumor came out with the fat and everything was under tension. Sometimes it depends on the size of the tumor also.
Yeah. Well, I don't do this kind of optic nerve resection because most of the time the chemotherapy works. Probably your experience is different. So I would put 10 years or 15 years. I did not have any opportunity to remove that optic nerve gliomas these days.
The indication actually is pain resistance to chemotherapy. Some of the cases we had chemotherapy, one even had radiation, and the tumor started regrowing. Then it is exophthalmos, which is bothering the child, and sometimes pain. And since chemotherapy is not reducing the volume of the tumor significantly, and these are the indications. I totally agree. The majority of all intraorbital tumors, there is no surgical indication, either because the patient has still some vision, which you don't want to sacrifice, or he lost vision and the tumor is small and he reacts to chemotherapy, no reason to treat it. So it's basically exophthalmos, pain, and resistance to previous therapy, which are the indications for this type of surgery.
Yeah, I agree with you, Martin, about this point. Great. That whenever it's impending the vision on the opposite side and going to the CAANS, and you lost vision in one eye, you need to preserve the rest. So sometimes you're faced to do the surgery.
Exactly. And if there's no exophthalmos or no pain, you can leave the rest of the tumor in the optic canal.
Okay, so yeah, any more questions? Yeah, okay. So thanks for all the speakers. I mean, we have had a nice 3 presentations. First, ependymoma, which take-home message is surgery, then surgery, then surgery. And then germ cell tumors, where you have your biopsy and endoscopy, and this dictates the rest of the treatment. And finally, the wonderful presentation from Martin for the CAANS gliomas, where you have to have an oncologist and you have to diagnose and preserve the vision and sometimes do the surgery. So pediatric neurosurgery, as you can see, a lot of varieties. And we learned a lot today, and thanks for the great speakers. And I want just to remind you always that we do these webinars very dedicated to pediatric neurosurgery with a series of webinars, second week of the second Tuesday of every month. So it's once a month, second Tuesday usually. And thanks for John for the casting and the wonderful TV. We have reached a lot of the neurosurgeons. And thanks for everyone. Yeah, Lil, do you have anything to add before closing? Yeah.
No, thanks, Mo. I think you covered all of it. Just a special thanks to John. I think you've done a great job. You do this kind of completely of your own volition, so we really appreciate it, John. Thanks for your effort.
Well, I thank all you guys for taking your time off to educate the world. And I think that the general neurosurgeons will get a lot out of this too, because as you know, that they don't see a lot of pediatrics, and it's good for them to see that. So we look forward to the next webinar, second Tuesday of next month.
Yeah.
Right? Okay, everyone.
Yeah. Okay.
We'll see you next time. Thank you.
Thank you. Take care.
Thank you, everyone. Thanks.
Stick around. Stick around. I'm going to stay here. I'm just stopping recording now. Yeah, and you know what?